Meeting is being recorded.
Perfect. Okay. All right, I'm going to let everybody in and then we'll get started. Good morning, everybody.
Good morning.
Good morning. We're just letting people in and we'll get started in just a minute.
Morning.
Hello.
Morning.
Good morning.
Morning.
Good morning. Just give it a few more seconds. All right. Ian, do you want to kick off our meeting today?
Yes, good morning, everyone. Welcome to the August meeting of Mprrac. Excited to have everyone here. I will call the meeting to order and take attendance. So, um, um, let's go person by person. Christopher, I see, is here. Welcome, Christopher. Do we have Manisha?
Yes, I'm here. Good morning.
Good morning, Manisha. Do we have Nicole?
Yes, I'm here. Good morning.
Good morning, Nicole. Do we have Kate Leslie?
Yep, I'm here.
Good morning, Kate. Hope you are well. Do we have Megan?
Good morning.
Good morning, Megan. Hope you are well. Do we have Tim?
Tim is here. Thank you.
Good morning, Tim. All right, I believe that is it, unless I'm forgetting someone. So I believe we have quorum and we are ready to get started. So I will pass back to Michelle and Brian to continue with the slides.
Awesome. Thank you so much, Ian. Thanks, everybody, for being here. Next slide, please. All right, here's our agenda for today. We'll go through the fiscal impact analyses from the June and July Mprrac recommendations. We always plan to take a lunch break around 11:30. Could be a little bit before, could be a little bit afterwards, but right around there as usual. We understand these meetings are very long. If you don't have the capacity to stay for the entire thing, don't worry, you can still send your email feedback to that email address on the screen there, and I'll also put it in the chat as well. And that will always be shared with the Mprrac. So don't feel like you missed your opportunity to give your feedback if you aren't able to stay for the whole meeting. We'll go through some next steps and announcements, and then we'll adjourn right around 2. A few housekeeping items as usual. Mprrac members, if you haven't already, please rename yourself to include Mprrac member, so that way the public can identify you. Any public stakeholders on the call, feel free to sign up to make a public comment. I did just drop the information in the chat for that. Just be sure to keep your comments to 2 minutes so we can ensure that everybody has the time to speak. And please try to refrain from repeating comments that have already been said. Again, just for the sake of time. Be sure to identify yourself before speaking. Please do not share any PHI. We speak in broad terms during these meetings, not personal. If it does happen, there is a way to scrub it from the recording so it can still be posted online. It just kind of slows down our processes a little bit. So just to avoid that and kind of get the recording out as soon as possible, don't mention any PHI. And as usual, please make sure to use the Q&A feature for questions instead of putting things in the chat. The chat is really reserved for links that our team is sharing, comments from the Mprrac members themselves. It just gets really convoluted very fast if we put everything in the chat. So if you have specific questions, please use the Q&A feature. That will be a lot easier for us to manage and make sure we're not missing your questions. Okay, next slide. So again, these materials always are being edited kind of right up to the point of the meeting. So they will go through the ADA remediation after the meeting and then reposted on our website. So this is just our usual disclaimer that they don't have time beforehand, it's always going to be afterwards, and we'll get those up right away as soon as they're ready on the website. Okay, I'll pass it over to Kevin Martin for this one.
I went over this at the last meeting, but just wanted to reiterate, we are looking at a very tight budget year. So in the last meeting, we talked about having multiple different recommendations from the committee, which has been incredibly helpful. I still don't know if we will be able to actually recommend anything from the department side within the report. But it still is helpful to have those for when budgets become less tight. Another thing that I really wanted to go over here is that and I know we talked about this very briefly in some other slides, but the purpose of the Mprrac is to make sure that we review everything on a regular cadence and see how access is looking and make any kind of recommendations. But just by necessity, there are other processes that rates get changed that are outside of Mprrac, because Mprrac is a bit of a slower process with all of the review and the public stakeholder meetings and all that kind of stuff. So this is just one means by which we review and recommend adjustments to rates. There are other avenues that are necessary to take sometimes. And I just don't want anyone to think that this is the only way that things change. And then I suppose the last thing sort of related to budget, I know this is all sort of hodgepodge, but it's all tied together with budget, is that the budget is tight enough that we're feeling it on the administrative services within the department as well. So we'd like the committee to really be thinking about, for the November meeting, what we can possibly be doing less of to be more efficient with this. Really think about what analyses have been helpful for your decision making, because we're probably not going to be able to put quite as much into it next year. It still exists and we'll still be doing everything that is required by law, but at the moment we do a lot above and beyond what is required by the law, and we want to just try and find some efficiencies there and cut out anything that is not absolutely necessary. I guess I'll leave it open, see if there's. Oh, and I guess one other thing about the recommendations from the committee, we also talked about prioritizing the recommendations in this meeting. Again, that would be very helpful. It's not required, but if that is something that the committee wants to take out and do, that would be very, very helpful for us. And with that, I'll leave it open for any questions, comments.
I think, thank you, Kevin, for sharing that. I think on both of those last couple of points, I think at the November meeting, we could discuss beyond the core analyses that you all do for every service. When do we do initial analyses so that if you all are feeling any, time, bandwidth capacity issues, that we're using your limited time wisely. And so sort of what are the criteria by which the committee are like asking for additional analyses before the beyond the kind of core set. I think that would be a good discussion in November. So I think we could bring that up then. And then I think the prioritization discussion we should do at the end of this meeting. So if we can just remember to save time at the very end once we've gone through services, I think that would be helpful.
That'd be great.
Michelle and Brian and Kevin, if you can just help me remind me of that 3.5 hours from now if I forget, that would be great.
Sounds good.
Oh, and this is Kate. Kevin, I just wanted to thank you for saying all that. And I really appreciate you helping us remember that there are multiple ways to make change and that we're all in this together. I do really appreciate it. And I am so sorry to hear that it's affecting y'all on the administrative side, but of course it is. So I just feel like over the last several years, we've created a really good working relationship with you guys on the HICPUF team and the analysis team. So if you guys have ideas about, cost benefit analysis for some of the work you do, where you're like, hey, we just spent a ton of time on this and didn't really produce a decision that you guys seem to be, or didn't, help with the decision making. So if you have suggestions, I know that's a lot more work, but if you have ideas about efficiencies, please bring them to November too. Because you guys know your processes and feel like you've been so helpful with us the last several years. When we've asked for something, you've done it, but you're the ones who know how much time it took, how much labor was involved. So yeah.
Yeah, we can absolutely bring some suggestions for things that seem to be high effort, low return.
Yep, that's the name of the game. Thank you, Evan.
Great. If there's no other questions, comments, I will pass it back to, what's the next slide? Probably Brian, maybe Michelle.
I think it's me this one. Thank you, Kevin.
Yep.
All right, so this is just a heads up to our chair, Ian, that the JVC presentation is coming up. It must be done before December 1st. So this is that presentation that you go before the JVC to discuss the provider rate review process, kind of the summary of the year and the recommendations, the feedback, and answer questions that they may have, which they will. So last year, Ian, when you were vice chair and Megan was chair, you joined kind of the prep meetings that we had with Megan. So that way you kind of knew what to expect for when you were chair. And we thought that was a good idea for this year as well. So for our vice chair to join the prep meetings with you. So just so the committee is aware, this is coming up. We'll have to work together to figure out some prep meetings and some practice runs and stuff like that. There's going to be a lot more details to come, but just a heads up, it's coming.
Yep, that all sounds good.
Yeah, okay, great. And yeah, I'm sure there'll be, lots of time for us to connect before then, obviously. So we'll be in touch about that.
And one other thing I at least wanted to state publicly here is that this really is a chance for the Mprrac committee or the chair in representing the committee to talk with the JBC. We help with meeting materials and coordination and everything like that. That is all just to try and lighten the burden of making that presentation, but we want to make absolutely sure that it is clear that we are not trying to put words into anyone's mouth. This is just to make it easier, and it is still your opinions that we want you to be able to convey to the JVC, not whatever we suggest in like PowerPoints or whatever. That's all just framework, so starting point.
Yeah.
Megan.
I may just suggest that in creating that presentation, not necessarily structuring it in the same order that we've reviewed over the course of these meetings, and consider structuring it more like if we used a similar sort of reasoning to make a decision on that set of codes, to group those together so the same information doesn't need to be repeated. And then I think we've made some helpful changes this year in being able to outline that thinking rather than having a bunch of slides with each individual, too much time spent on each individual recommendation to leave more time for discussion, because I imagine this will be another year where they have a lot of questions.
Yeah, I think that's a really great suggestion, Megan. Thank you for that. I'll be sure to take that into consideration when making the PowerPoint. And yeah, Kevin, thank you for saying that. Definitely, this is your guys' meeting. We're just kind of helping with the back end, getting it all set up and everything. So if there is like Megan just suggested, like suggestions, it's your PowerPoint. It's just, we're just making it for you so you don't have to like do it. And then you feel free to either tell us how to edit it or you edit it yourself. But yeah, definitely your meeting, your direction. Thank you for making that clarification, Kevin.
Megan, any other suggestions from your experience last year for me, either for the slides itself or the conversation, like anything else come to mind?
I think that was the big thing. I think I walked into it not really understanding what they wanted to hear, and so spent a lot of time on like, this is each individual recommendation, and especially being a tight budget year, they wanted to understand more of those trade-offs. And I think, this presentation and the way that we've approached things, I think makes the trade-offs and priorities hopefully clearer. But I think being able to, speak to that. And then there are codes that we treat sort of similarly because they all have, Medicare benchmarks, or they all have, the majority have like state-based benchmarks, and things like that. So I think, again, putting those together, but really more focus on the like, this is why we made this recommendation, and these are the trade-offs. And if we really can't do any of this, like, I think it does sound like we're going to be in a spot of just having to lay out what our goals and our priorities are, but really, again, where we had to be pragmatic.
Thank you.
Right. Thanks for that discussion. All right, I'll hand it off to Brian.
Thank you. Good morning, everybody. Brian Poole, and I'll be your facilitator as always today. Looking forward to this. Just as a few reminders as we get set up here today about our roles. As has been mentioned, the committee here is legislatively appointed and collaborates with the department, but is not staff. The staff is just tasked with synthesizing the analyses and sharing those with us, and then to develop the recommendations for rate or policy changes, and then those are agreed to today, for example, for the rate changes and recommendations by the committee. The recommendations may result in future budget actions by the department, but those must be approved by the legislature as always. And any review of services, including the analysis, does not guarantee those changes, whether increase or decrease, or any changes to policy. As a reminder, the committee does not submit actual budget requests. The budget requests are submitted by staff of the department, and that process is independent of this rate review process. And the committee does not have the authority to change rates without the legislative approval and the associated appropriation. As always, we've been doing very well on our governance, emphasis really heavily on self-governance by the committee and our chairs. We want a respectful, safe environment for everyone, and a focus on easy communication with one speaker at a time, for example, folks staying on mute, and being tough on the problems facing our state and easy on each other here, using the past to describe only a better future. And as always, we're expecting folks to come prepared, having read all the materials and feedback from stakeholders in advance of the meetings. Some important things here today on our terms. Again, we've mentioned this, but the orange terms are in their last year of their term, and we have some news to announce today. So first, I'll note that while Kate is highlighted here and interested in another term, we can confirm that she's been formally nominated by the President of the Senate and is on track for another term. So thanks, Kate, for your work, and look forward to seeing you next year. The others are in. That's right. Yeah. The others are in process. So more to come on those as we get closer to November. And importantly, we want to mention that Christopher has asked to withdraw from his role as our vice chair. So in respect to his request, we're going to make that effective today. And that means that we need to look to establish a new vice chair today, and in fact now. So I'll give you a moment to think about this. If you are on the committee, this would be an opportunity to elevate your role and help Chris to recede per his wishes. And then just a few notes here. So if we can establish that there is a new vice chair today, then that person would be effective immediately, become the vice chair for today and for the next meeting. And then, as per our practice, typically we establish the rule that the vice chair from this year will become the chair in the following year. So, if you do put your name forward here for a vice chair role, expect that in March you would be the chair through next November. And that then would vacate the chair, the vice chair role. So in our November meeting, you can expect to have another election for a new vice chair for next year, who would then become the chair in 2028, presumably. So just trying to lay out the calendars there for folks. And at this point, I'll pause. If there are anybody who would like to nominate someone, including yourself, we'd love to hear about that.
Is anyone interested in the vice chair role?
I'm always willing to help out, but I also would love, if others would like to take that role.
And just to reiterate, like Brian said, this person would be chair next year. So it's more of a lift next year than it would be for the rest of this year, just to reiterate.
And if that is intimidating, I'm happy to do chair again and have someone be a vice chair, stay as vice chair next year, then become the chair the year after, so they get a little bit more experience in the earlier meetings. I don't have a strong preference. I'm fine either way.
Yeah, so I actually would vote for that. I did the vice chair role for 2 years, and I think sometimes like having some consistency can be helpful. So I would be in support of that.
I support that too, Megan. Yeah, I think it's really helpful to have a mentor for a year before you're in charge.
I agree. And I've only been here since the June meeting, so I don't think I'm in any way ready for any of it.
And I would support that idea too, if Ian's willing to do it. And just so you all know, this is not a never from me. This is just not today.
Thank you, Christopher.
And
Yeah,
if I add, I'm sorry, I also has just joined the committee this year, and as much I want to participate, I want to sit out, learn more, and then nominate. So by elimination, if we are getting shorter, I would like to eliminate myself for now, like Christopher said.
Thank you.
And for the new members, this is Kate. I like to think of myself as an outside agitator. I just like to keep, I like to be I don't want to be in leadership because I want to say I support, the stakeholders, and I really appreciate being on this committee. But when I'm in leadership, it's a different role. So I would prefer to stay in my role as like not in leadership but able to push. That's my preferred position. So I will not be doing that. But does that leave anyone else? Because we have 2 chair members. We have 2 new members, me, and then who else could possibly take that leadership role?
That'll be Tim.
And I think Tim is role.
So, yeah, this is Tim, and I'm still trying to determine if I want to have another term. I've been on the committee since its inception. I have been both the chair and the vice chair previously. So at the moment, I am not interested in being the vice chair.
My audio unfortunately cut out a little bit as people were talking. I just want to make sure I got this right. Megan is happy to help. Christopher is not able to help now, maybe in the future, but not now. Nicole, I believe, was not interested. Tim is on the fence and therefore not interested. Kate, you said you were not interested, and Manisha, did you say you were interested or were not interested? It was like cutting out as you were talking.
I was hoping to wait it out for now to learn
Wait,
more
no.
about
Okay.
Yes.
Okay. So then that would leave you, Megan.
That leaves you, Megan. Sorry.
So do you and then you've done it before, so I'm fine either way. Like, how do you feel about that overall? And then would you want to do like shorter vice chair into chair next year, which I would be fine with, or extended vice chair for another year to then be chair the year after that? Do you have a preference either way?
I don't have a preference. I mean, it sounded like the vote for next year's chair we had intended to, or was scheduled for November.
Right. We don't have to decide that today. Yep.
Yeah. I mean, so if we want to decide today, I guess my vote would be like do the vice chair thing, this year and next year, and let you do the two in a row. But I feel comfortable either way.
I appreciate your leadership, Megan. I just wanted to let you know that. So, and I appreciate your leadership, too, Ian. You guys have both been great.
So this is a question to Brian from a procedural standpoint, bylaw standpoint. Can we actually make this decision today, or do we need to vote in the vice chair today and then maybe do this again in November? It's a procedural thing.
Yeah. We just want to do our vice chair for this year, and then next in the next meeting in November we'll do the vice chair for next year. Yep.
Okay.
Well, I guess so. Ian can't be both vice chair and chair at the same time, can he?
So I think what we're saying is we would make Megan you the vice chair today.
Okay.
Then we will reevaluate at the November meeting.
Okay.
I would ask, especially the members who are not me or Megan, so Nicole, Kate, Manisha, potentially Tim, depending on your future on the committee. Are you potentially interested next year for the role? Think about that. And at the November meeting, we can either, I think we would have a decision of two paths. One would be I stay as chair for 2027, you stay as vice chair for 2027, or you become chair in 2027, Megan, and someone else becomes vice chair in 2027, and we can make that decision in November. Does that sound good to everyone?
Yeah. Thank you.
I support that for sure.
Okay.
Yes. So do I. Thank you.
All right. I think we have a decision, Brian, and yeah, we can keep going.
Yep. Thanks, everybody. That was very clear. We will operate as such. Okay, meeting structure. We review this each time. I think everybody's pretty clear now. Initial data comes in March, and then our June, July meetings, we work out with the analyses and make recommendations. In August, we get the fiscal impact of such recommendations. And then in November, we turn to lessons learned, training, and planning for the following year. So today, we're going to really focus on the fiscal impact of your recommendations. If there are changes as a result, we can make those today, or we can keep them in place as desired by the committee. And then we'll look forward to November. As a reminder, the department is not able to share the draft report or the recommendations ahead of time. The recommendations will be taken into consideration when deciding the departments, as well as other budget considerations that are made outside of this committee. And then any amendments to those recommendations may not be included in those recommendations. Some analyses will be updated in the final report based on the providers and subject matter experts and the committee, but may not be reflected in this presentation today. And we need to approve our minutes from the summer meetings. So that will be.
I will move that we approve those minutes.
Thank you.
Maybe just to avoid confusion, Megan, can you also move, since technically we have the vice chair move?
Yes.
And just have both of you do it.
That's right.
Yeah. Any comments about the minutes from our last meetings?
No, thank you. They were excellent.
All right. If so, then I will move that we approve our minutes from June and July. Any objections? Hearing none, then we'll approve our minutes. Thank you.
Thank you.
Thanks, Megan. All right. Couple things here. So this is our cycle, cycle 2, year 1, 2026. These are the services under review. So we'll cover these. We've got maternity through anesthesia, ambulatory surgical centers, dental, behavioral health, and our surgeries, a slate of surgeries. Now, important here, we have some approvals. We need your approval on this. There have been some changes to cycle 2, year 2, our 2027 schedule, essentially. So I want to cover a couple of these specifically now. You'll see home health services, or HH, will now have 2 subcategories. You can see those bolded in there: acute as an addition and long-term as an addition. That's in the second row. So I want to make that clear to everybody. We will have both of those as subservices, subcategories. And then CDAS, which you see a little further down, and this has no longer part of HCBS, so it's removed. Well, it was further down in the prior version, but is now removed, and it's included in the CFC category. So you can see that it's become sort of a subcategory itself. And then finally, at the very bottom of the slide, you'll see TCM, case management and transition coordinator, will be moved to the 2028 year. This is going to allow the department more time to investigate and develop a plan to implement items contained in the 2025 recommendations. Because that TCM is a different service, the EI TCM, that's going to be, it will remain in 2027 and help distinguish it from other TCM categories. So a little bit of shuffling here, nothing too material, but just wanted to be really clear that you know what to expect next year.
Can I ask, is the early intervention targeted case management like really different from the other case management services, or are we going to end up in a, I don't know, similar situation to where we've been with dental and I think a few other services where we review them in different years and then feel like we have trouble making a good comparison?
Kim?
Yeah, sorry, can't get my video to turn on. The early intervention TCM is completely different. It's on a different fee schedule. The members that it serves are different. The providers are different. The policy is different. It's a completely different service, and it'll probably be beneficial to carve it out from the other TCM services anyways, because of how distinct it is from the other two. Does that help, Megan?
Yes, thanks for that.
Yeah, thank you.
Okay. Is everyone comfortable with this new slate for 2027? We're looking for your approval.
Any feedback from members here? All right. Motion to approve this cycle 2, year 2 for 2027.
I'll move to approve.
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 Approved.
Approved.
All right.
Perfect.
Keep going.
Thanks, everybody. All right, let's dive into your recommendations and the fiscal impact associated with those. So just a quick explanation of our internal recommendation consistency. Since the 2024 review, the committee has considered codes with a valid fee-for-service rates, but no available benchmark rates during recommendation development. These codes are generally considered alongside regular codes with established benchmark ratios. And when no change is recommended for benchmark codes, we recommend no inflation adjustment for non-benchmark codes to maintain consistency across the code set.
Can you just go back to that for a second, Brian? I just want to make sure I understand it. You're saying that most codes have a benchmark. There's a small number that don't. We typically recommend an inflation adjustment that has been about 3% in the last couple of years. You're saying if we are recommending no change for a code, we should not recommend the 3% inflation adjustment. And Can someone from the department just speak more to that, just so we understand the logic here?
I can speak. Before the 2024 review, like a long history, we only focus on the code with a benchmark ratio. So that naturally leave those code without benchmark ratio in the column, just like ignored completely. And then we recommend, if you have a recommendation, to the majority of the code with benchmark ratio, so you should not forget about them. But this year, due to the budget situation, you very considerably have two set of recommendation, like ideal and pragmatic. And that happened for the pragmatic. Sometimes you say no change to the code with benchmark ratio, and you naturally remember to give the 3% of the inflection adjustment for the code with a benchmark ratio. If this goes along, it will looks like a little bit awkward for the whole service category. Like you don't increase the rates for the 99% of the code, then you only increase 1% of the code. So we suggest that maybe we take back a little bit to maintain a better consistency. How do you think?
I think that'll be a helpful thing to discuss as we like roll through the recommendations and the each of those sections where we've made the no change recommendation and the 3% for the non-benchmark codes. But I think it's a helpful thing an issue to.
I think it's a helpful thing to raise, and I think we can address it as we go service by service.
Sure.
Thank you.
That works. Thanks, everybody. Okay, so overall fiscal impact, again, we're going to use the terms ideal and pragmatic throughout our presentation today. Just as a reminder, ideal is what you would do ideally, and that is actually your intent overall. However, when we've asked you to provide some sense of where your priorities are, or acknowledging the fiscal challenge facing the state and the department as a whole, you've then selected, and we'll have two categories here. Your first, we'll talk about the ideal, and then the pragmatic. So, for example, total funds, 100 million in your ideal recognition, of that 29 million in general funds, and reappropriated 2.4 million. And then for the pragmatic version, we now are at 3.6 million increase. That's and a negative general fund impact. And reappropriated would be 1.9 million. So quite a difference, obviously, between the ideal and the pragmatic recommendations. You can see that on the slide overall.
Can someone speak to what the reappropriated means? I'm aware of the total and general fund, and we've talked about that before. I think the reappropriated may be new. Can someone speak to that and what that means?
Kim?
Yeah, let me see if I can. Oh, there's my video. Hi, Ian. The reappropriated funds, that is part of the nurse home visitor program. That particular service does not use any general fund. They have these funds that are reappropriated from CDEC through the Tobacco Master Settlement Fund. So it's just a different bucket where that money comes from. So
we would still, in the bottom right, have $1.9 million. It just doesn't come from the general fund. It comes from this separate fund that you're mentioning.
Yes.
Okay.
Yes.
Okay, makes sense. Thank you.
You're welcome.
Okay. All right, let's dive into non-emergent medical transportation and EMT. So your recommendations, ideally raise rates below 100% of benchmark to the benchmark. Rates that are above 100% would stay the same. And then looking at a 3% increase for codes without a benchmark. On the pragmatic side, you said leave the rates the same and have a 3% increase for codes without a benchmark. So the ideal recommendation on the bottom left here, total impact of 20.9 million in total funds, and general funds of that would be 6.2. On the pragmatic side, a very incremental increase of $120. So that's the 3% increase to the codes that have no benchmark.
Here is an example for the consistency for the pragmatic recommendation.
We have public comments.
Yes, we have one person signed up, Michael H.
Michael, you there?
Yes.
Michael H.
Yes.
2 minutes. 2 minutes, please, sir.
Yes. So I don't know if you guys, thank you for this opportunity. This is my first time joining your meeting. I am one of the 9 county transportation and emergency medical transportation providers. There are actually a lot of providers that are watching and listening. We are on the verge of collapse. We are at the point where we cannot cover insurance, payroll, any of the costs. The immediate and unexpected cut that happened is unbearable. I can attest to several of the providers that we are actually paying out of pocket to provide service. We're paying drivers out of our pocket. The money that is being paid right now is not covering payroll. Insurance increased. Actually, with the new provider, there is increased requirement for the insurance side. We pay workers' comp. We pay several costs. I can email you in detail. But we really urge you to help providers and to also help our patients that need this service. So I strongly recommend returning the rate to where it was at least, so that we can survive and continue to serve our community and keep our workforce. We are literally at the point where it's like the whole completely the non-emergency transportation service is about to collapse. So I really urge you guys to look into this. You can call, you can communicate with us. I put my email, my phone number. We are trying day and night to get help from someone to hear us and fix this immediately before it is too late. We're losing our best drivers, best people to other tracking companies and stuff like that. So all we are asking is at least return it back to where it was to survive, and not even to make a profit.
2 minutes. Thanks, Michael.
Thank you so much. I appreciate the opportunity.
That's all the public comment we have.
Thanks, Michelle. Members?
Any member feedback on our earlier recommendation? Can you go back to slide 21?
Yeah, I guess my question is, I feel like when we reviewed these, we saw like where things were based on the adjustment that happened, kind of like where the benchmark was based on the adjustment that happened. But like if like the commenter is saying return to where things were, where is that in terms of the relative benchmark? Was that at 100%? Was that at 80%? Was that at 60%? Just to get some perspective.
Ling.
My understanding is they have 2 code. Cole, can you please bring up that 2 code? They reduced from more than $30 to $12-ish on July 1st, 2026.
Let me just, this is Cole here, sorry, got my video off. Let me double check that real fast. It is the mobility van base rate, A0120. And there were 4 targeted codes that underwent the decrease. I don't know, you guys were mentioning 2, but I have mobility van base rate and taxi cab base rates, and then the mileage S0209, S0215 codes.
That 2 mileage code has very small reduction, like reduced from $3 to $2.80-ish. the biggest reduction is that two code, the van taxi and the mobility, there are two code.
Manisha?
I also would like to emphasize here that we see the fiscal impact of the regular or ideal recommendation. What we are not able to see right now is the impact that would have if any MT was to collapse. It's not saving the budget by not giving them what they want. It also is going to add more to the budget because then it would end up with emergency transportation. And I always feel I see what this is going to cost, but I always miss out on not providing this is going to cost how much more.
Tim?
And thank you for that comment, because I'm kind of going to reiterate that, being an EMT provider myself. If what the stakeholder said is true and we lose more and more in EMT providers, what is that going to do to the EMT side? What kind of strain is that going to cause for availability of emergency services? And also, I'm really trying to understand the difference, because those numbers are stark between the ideal recommendation and the pragmatic recommendation. I guess I kind of need a little bit more information to understand exactly what these are saying, because it looks like there's no money for NEMT in the pragmatic recommendation.
Cole?
Oh, there's audio. I could provide a little context to that. So our A0425, which is NEMT ground ambulance mileage code, that was a code that was, or it's currently at 78% of the benchmark. And so when we raise it to 100 under the ideal recommendation, since it's such a heavily utilized service, that had such a profound fiscal impact, and it actually comprised of almost $20 million. So it was pretty much the gist of what you're seeing under the table under the ideal side comes from that A0425 fiscal impact when we raise from 78% to 100% of the benchmark.
Megan?
So if I'm understanding correctly, you're saying like where things currently were with the rate decrease that they got was 78% of the benchmark, and we requested this increase to 100%. I think my question still is, like, with where the rates were previously, how does that compare to this 100% recommendation? Because if we were to make some intermediate recommendation, like I don't think we can make the ideal recommendation, and it doesn't sound like the 78% of benchmark is sustainable. Just deciding on an intermediary recommendation, I'm trying to understand how that would compare to where things were prior to the decrease.
Lingling?
Context for Megan. For the 85% reduction, that's for those code with benchmark rate with Medicare rates. For non-EMT, the whole service category, we benchmark against other states. And this huge reduction, effective on July 26, it's separate to that 85% of Medicare reduction.
I think the slide in last month's or last meeting's deck was helpful to show the code level benchmark ratios. I think there's sort of like two things which can both be true. One is what the stakeholders are saying, which is that there's been a major cut to reimbursement that came from the JBC and was implemented very recently. I think there are actually multiple cuts implemented over multiple months that I think were in full effect in roughly July and are like very large cuts, consistent with the provider comments. I think the second piece is that the analysis that we looked at in the previous meeting was that even post-cut, and Ling, correct me if I'm wrong, but I believe the data that we shared in the meeting was the July 1st effective rates were still for many codes above benchmark, like north of 100%. And so that led to the ideal recommendation, which is here on this slide, which is anything above 100% leave the same, and then anything under 100% bring up to 100%. And so I just want to remind folks of that logic of what led to this ideal recommendation on the left-hand side.
Thanks for that context, Ian. Yeah.
Go ahead.
Oh, no, I was just going to say, so I think what, Ian, just to keep going with what you were saying, is that so our ideal recommendation did come from seeing how low the rates were. I mean, our ideal recommendation would be 20 million. That would be the fiscal impact, with the increase in the general fund as well. This is the best probably we can do. I guess the other question I had, and this is probably not for this meeting, but I just know that those reductions from the JBC and that were internal, had to do with the feeling that these rates had been, there was a fraudulent case. So, it's okay to say, like, yes, those rates were drastically reduced to close that budget loophole, which the JBC is doing everywhere, right? They're just trying to close so many budget loopholes. We just want to make sure that when we reduce rates, we don't cut into the muscle, right? We're cutting everything we can possibly cut while still making it a functional service. And as I'm looking in the stakeholder comments, which are very, very helpful, there's a bunch of different codes that they're particularly concerned about. But again, this would be our recommendation is, this is our ideal, this is the pragmatic, that's what we can recommend. I don't know if there's anything else that Mprrac can do at this point, maybe is what I'm trying to explain to stakeholders. But, I'm happy to be wrong about that. If Megan or Ian or others feel like there's something else we could do for stakeholders, or Ling, if HICPUF has a recommendation. But go ahead, Ian. No, that's it.
The thing that came to mind to me was to do a recommendation to the JBC to do an actual cost study. I believe these rate reductions were based off of Medicaid state benchmarks. And so basically what the providers are saying is that these rates don't cover the cost. And so a formal health economic study can look at provider costs built up and then can and then can build rates from there. That is more expensive. But for something like this that feels so dire from the stakeholders, which I deeply empathize with, like that could be a step we could recommend to actually make sure that we haven't cut, as you're saying, Kate, beyond into the muscle and into the bone.
Yeah, that's what I'm trying to say, Ian, that sometimes when there's this fraudulent happening, then as a JBC, they swing really far. And that's what happened. And then we can say, yeah, that might have been too far, but we do need an economic analysis to say what would be a more reasonable rate. That might be outside of our purview in this committee. This would be what we do, at least what the work of this committee is like. So yeah, I'll stop now. I know we have a lot of hands.
Ling.
Yes, for the A0100 and A0120, after reduction, they meet at the 100% of the benchmark rate. Here, I know some non-EMT provider already communicated with us. They have a concern on our benchmark list. I totally understand. And don't forget, we have a full review for EMT and non-EMT next year. And this summer, we will have provider engagement work group meetings. So we would like to listen to more to the non-EMT provider, maybe change the benchmark list. Yeah.
Thank you for that, Ling. That's really helpful to know that HICPUF is also trying to make sure there's economic viability. I appreciate that.
Megan?
Yeah, I mean, I think it feels tough to make the pragmatic recommendation, hearing the impact on stakeholders, but also knowing that we're going to be doing a full review next year. I feel like I could get comfortable with that. I'm still just trying to wrap my head around if we said, raise rates below 80% of the benchmark to 80%, does that have any impact? It sounds like perhaps not a lot. Maybe on that mileage, which was sitting at 78%, but a number of those codes were still around the 100% of benchmark, if I'm looking correctly at those slides from last time.
Langley?
Let me see. Megan, sorry, I'm just multitasking. Could you just repeat your question?
I guess it was more of a statement. I'm just, if we made a revision to our ideal recommendation and lowered it to 90% or 80% of benchmark, does that provide some benefit but not have as huge a financial impact? And I'm trying to understand how that compares to where things were prior to the cut.
I believe, Megan, I might be wrong on this, and Ling, please correct me if I'm wrong, but all the codes the commenters are citing in the chat are all at 100% or above. And so if you were to bring it down to 90%, it actually wouldn't address the concern because those codes wouldn't be lifted. So that's the fundamental challenge is I hear the stakeholders, I empathize deeply, but these are codes that are already at some are at 100%, some are at above 100%. There's a range, but they're all at or above 100%. And so, I'm not trying to poo-poo what you're doing. I understand the spirit of what you're doing, but I don't think it would make a difference. They're wanting codes that are at or above 100% to be even further above 100%. That's the challenge.
Great. That's what I was trying to understand. So that's helpful, and I feel more comfortable with sort of the reality that we probably need to leave the rates the same and do the evaluation next year.
And Ling, please correct me if I'm wrong on what I'm saying. I want to make sure I'm not making a mistake.
Sure. Yes, you are correct. And so, as I mentioned, if the benchmark status to get a change, the benchmark ratio will naturally change. Yeah, that's a potential direction. Alex or Courtney are on the call. They are the non-EMD policy specialist.
Tim?
Just wondering, based on our previous I'm sorry.
Go ahead, Tim.
So based on our previous conversation, if we're going to review this again next year, and if we're recommending some sort of cost analysis, which would probably require a cost report to better understand this program, does HCPF have the staff and the time to create this cost report and analyze it so that we can come up with a better recommendation next year?
Tim, thank you. I think your question is very good. I don't know at the moment. I think you need a JBC approval to give us additional funding for cost analysis. And in addition,
so we could be in the same boat next year that we are right now. Without
the difference is the benchmark status that will be probably get changed.
Yeah, so if the benchmark changes, then we could actually have different data next time to review, right? Yeah,
yes.
Thanks, Ling. Yeah, and the stakeholders did mention the benchmark being their concern, right? Because they're trying to add in the idea, which is really true, that Colorado's cost of labor is really high, and so we have to be careful of that in our economic analysis. Yeah.
Manisha?
And we've done. Oh, sorry, just to follow up. And we've done that before as a Mprrac. We've made that recommendation where we said this is our rate recommendation based on the current benchmark, but we would like this to be, et cetera, like economically reviewed due to labor costs. We'd like those benchmarks reviewed. Like we can support this continued conversation that will happen with HCPF. That we've made those recommendations before.
Manisha?
I would like to second what Tim was saying. Benchmark states, I I understand that there is going to be an additional cost involved to get approval from JBC to do the actual cost analysis, but I really feel that is the way to go forward. No benchmarks that we cannot compare what the stakeholders were saying. Some states have different codes. Every state is so unique. And then we talk about this even in our dental groups that what are we looking at? Are other states looking at us and we are looking at them and going bouncing off of each other? Or are we really doing the cost analysis? Cost of living's going up. So again, to reiterate what Tim said, maybe find out with JBC if we can do an actual cost analysis.
Thank you. Okay, any changes then to the recommendations there?
I mean, I think then the only other piece is to discuss the 3% and do we want to, if we're making the pragmatic recommendation for this year, to leave the unbenchmarked codes the same in this category that seems like the impact is negligible.
I think it's negligible, and I think we just leave it alone is kind of my thinking, Megan. And my thinking is to then add a policy recommend. I would recommend that we keep the recommendation the same. That would be consistent with how we've operated as a committee for multiple years on similarly situated services. And then add a policy recommendation to the JBC to fund some more detailed benchmark on NEMT to really ensure that we are setting rates appropriately. That could be the cost benchmark that I suggested. It could be a 50-state benchmark, but basically more resources analytically for this service line so that we can feel really good next year when we go into our non-out of cycle review that we are setting rates appropriately. I don't know another step we could take. That feels like a reasonable step to help address some of the stakeholder feedback, but yeah, curious what other committee members think.
I support that.
I have a question about that one. And I know when Megan was talking about bringing the codes from 100 to 80 or 90, and Ian, you mentioned that the codes that we are talking about are already above 100. So, what is this big difference of $20 million that's coming? What is it that we can go land halfway? Maybe change our ideal recommendation that it does not get kicked off right away and we land with pragmatic. Can we not come up with something that's $5 million instead of $20 million and give a string to hold on to for the NEMT providers until we do this over again next year?
Yeah, the response I heard to that was that it's primarily the A0425 code, which is the mileage code, which was at around 78% of benchmark, and a frequently used code. So increasing that one to 100% was the majority of that. And somebody can correct me if I said that wrong.
That's what I heard too, Megan.
Say that code one more time, Megan. What was it?
A0425.
And you're saying to bring that up to what? To 80%, to 100%?
Yeah, what would be our recommendation were we bringing it up to 100 and that caused the 20 million, or are we bringing it up to 80 and that would be a less fiscal impact?
I mean, I think the question is, would bringing it up to 80 or 85 lessen some of the impact both on the NMT providers and on the fiscal impact?
And we have done that before as a committee. We've specified one specific code that we felt like we could make a recommendation on. I think that's many.
The other thing we could do is bring any code below 80% up to 80%. I'm looking at the last meeting's deck, and there are codes below 80%, and we could just bring every code below 80% up to 80%, even in the pragmatic. So I think either are reasonable, targeted to a 0425 or kind of blanket across the board for anything below 80%? Do folks have a feeling on either of those or something different?
Tim?
I'm just wondering, especially with the passage of House Bill 1069 last year, authorizing Medicaid payment for treatment in place and transport to alternative destinations. Even as we watch the impacts of the decision we're making today, can HICPUF watch and see if there's any change in emergency volume with potentially losses of NEMT providers in this space? Because, I mean, you're going to be paying more for the ambulance to take these people even to alternative destinations. It's an interesting dynamic, I mean, to watch, because once again, we're going to see, if the stakeholders are correct in this, we're going to see fewer NEMT providers. You're going to see more EMT providers potentially transporting these patients to alternative destinations using ambulance rates to do that. And that's going to be a huge fiscal impact on HICPUF as well. Huge, bigly.
Ian, can I ask you, as chair, when we get close here to recommendation, to make sure we drop that in the chat so folks are clear on the language?
Yes.
If we decide to change something here. Megan?
Yes, like as we write the report, I would love to see in there both the ideal and the pragmatic recommendation, just so that, you know, if any readers are looking at it, they understand that there were some trade-offs that were made. And I think my proposal in this situation would be we change the ideal recommendation to be bringing codes that are under 80% up to 80%, since we don't really know what the financial impact of that is right now, and keep the pragmatic recommendation being no change. And just given the other codes we'll talk about later that we suggested no change and the 3% increase, I would just propose that we do the no change across the board, even though here it is really minimal difference.
We want to put that in the chat?
Mr. Brian, this is the provider that gave comment earlier. They are a bunch of
Michael, I'll have to ask you if the members want to hear additionally from other contributors, would we allow you to speak at this point?
It's not contribution at all. There are people that are trying to engage.
Michael, I have to ask you to please.
I think it's okay, Brian. Let's let him finish the comment. Michael, if you can go ahead and.
Okay, thank you.
They didn't know how to put the comment on where I put the comment. So they are on the chat. There are a bunch of providers. We are literally out of breath right now. So they are trying to speak to you, but they didn't know how I did it. That to comment on their side of the story. I'm not trying to add anything additional. Currently, what we are getting paid is not even legal minimum wage. So we're gonna be like, if we're thinking about to talk about a year after, maybe we have to say our goodbye now. I don't think there is a way that we're gonna stay a year like this. So there are people that are trying to speak. If you could give them a chance for the people that are raising their hand. I just don't want to be the only provider speaking.
Michael, I really feel your difficulty. I was also a provider from my stakeholder community before I joined as a member of this committee. We are reading their chats, and that is what's influencing our discussion. If they have additional information, they're welcome to put that in there, but this is our process. So you do have to sign up ahead of time. You have to have prepared remarks and you get those 2 minutes. I think what we're offering as a committee is the best we can do as the committee, which is to say what the pragmatic recommendation is here that Megan just put in. I think that's a great recommendation. Just so you know, Michael, I know this isn't much of a solve for you, but as a mental health provider, I was in the exact same position as your industry like 4 years ago, maybe 5 now during the pandemic. I know Ian's companies as well have been in the same position as you are and your stakeholders are. So what we're offering to you might not feel as helpful as you want it to be, but this is our process in this committee. And actually what we are doing, this is the power we have. So again, if there are stakeholders that have additional things to say and add, I understand that. So the best way to do that going forward is to continue to work with the HICPUF's committee. We are recommending that they look at the benchmarks. That's a big deal. So we really appreciate that. HICPUF just put another email source in the chat. So if you have feedback that you didn't get to say today, please do email that. We read it. HICPUF reads it. It's recorded. So that's one way to do it. The other way to do it is to lobby the JBC directly. If any of your constituents are members of their districts, they are allowed to lobby their representatives directly. I have done that myself. There are other ways to do that as well. If you want to support local journalism, you can go to the journalists and report these things. They're really important ways to lobby your democratic government. I do know it's frustrating that this is the way this committee functions, and this is what we can do. So, and thank you for posting the ways to sign up for additional public comment. So I hope that's of use to you.
Kate, thanks for saying that. And Michael, I want to just echo what Kate said. I own my own private practices, and these are things that keep me up at night. And we take this so seriously as providers. And I'm watching the chats and I can see how worried everyone is. And I agree with Kate, like we're trying to make recommendations that we think are going to get passed as well, but also meet some of the immediate needs. Because we can't influence the budget directly. These are recommendations that we think, what can we ask for that's going to actually make some kind of supportive change? So thank you for being so passionate, Michael.
I agree with everything that Nicole and Kate said. The other piece I would add, just for clarity, is that our rates are for recommendations 1 year from now. So the recommendations that we put into place, or that we recommend, and that HICPUF and the JBC would work to put into place, would be for July 1st, 2027. So if there are real, I read the direness of the comments in the chat and I treat it seriously. We are not able to help from now until July 1st, 2027. At that level of need, an emergency need, that is really a JBC question, not an Mprrac question. This is more a regular review cycle for ongoing cadence, not an emergency rate request.
Yeah, thanks, Ian. It's really important for folks to know that we're making recommendations for next fiscal year. In the current crisis, then it's really important to take action as you see fit. Like, again, lobby the JBC directly. They are the decision makers. But just so you know, like, this committee does matter. The JBC does take our recommendations into consideration, and so does HICPUF.
I want to, go ahead, Ian. Sorry, I don't know how to raise my hand.
Go ahead.
I want to just, I think some of my value at the moment too is just being sort of new to this and novel to this. And so I'm going to ask the questions that maybe are a little confusing. So in essence, what we're recommending is no change. Is that what I'm hearing? Like no change?
No. So I would like to see both of our recommendations go through so that if somewhere the state finds some money, that they understand that we would like people to have increases that help to make their businesses functional. And at the same time, if we're just in another like tremendous budget shortfall, that like, again, that there is sort of a pragmatic recommendation. I think the thing that was really challenging, especially last year, was that we, made our ideal recommendations based on stakeholder feedback. And then that went to the JBC and they're like clearly nobody understands, or clearly you guys don't understand like where we are. And then our recommendations really had no impact because like they just had to make some really, really tough decisions. And so now we're just trying to offer a little bit more support on both ends. We want to advocate for the needs of everyone that is providing these services, and we want to sort of take into account the reality of our current budget situation.
Yeah, and I would emphasize here, just a quick time check for everyone. We have a number of services to cover today, and we've probably 45 minutes on this one. So we cannot sustain this level of analysis. We need to get to a recommendation and a discussion from the committee, or we won't be able to finish.
So Megan, I like the direction of your recommendation, but I would put it in the pragmatic, not in the ideal. In the ideal, I think you're actually reducing the amount, you're raising it less. I think what we would say if we kept the ideal the same, and then on the pragmatic side, we would say bring below 80% up to 80% to make sure there's no um, um, true negative outliers. Um, I think that might be a better way to do it.
I agree with that.
As a reminder, Ian, if you could put that in the chat so we have it easily accessible. Ian or Megan.
I'll do it right now. Yeah.
And while Ian, you're doing that, may I also make a request to HICPUF? I am still not keeping up with the codes and how much would changing the codes from 78% to 80% make a difference, or 80 to 100 would make a difference. But looking at the final fiscal impact, if this recommendation changes from 20 million to 19.5 million, instead of presenting it next time as this is what the fiscal impact is, I would want help from HICPUF to say, instead, if you do this, this would be a $5 million deficit. Can we do this instead of waiting until the next meeting to find out, or whatever you said just saved us $200,000?
So I think the challenge of timing is that we won't have the opportunity to see the fiscal impact of this change to our ideal recommendation, or change to the pragmatic recommendation, whichever route we go. And so I think that is why I had leaned towards my recommendation of just like, if we think that the impact is a handful of codes that are sitting less than 80%, to address those, knowing that, you know, this 20 million or whatever that impact is just not possible. Like I don't personally feel comfortable like making that recommendation, and so I have some difficulty with keeping that ideal recommendation, but we're not going to know what the fiscal impact of a lesser increase is kind of before things move forward.
So we have Ian's recommendation: ideal stay the same, pragmatic increase 80, under 80 to 80, and a policy confunding a more detailed rate study to ensure appropriateness.
So Megan, just so I understand what you're saying like the $20 million number on slide 21 is so large that in the current budget setting it's not going to be taken up, and so you're trying to actually lower that so that it's a more reasonable number that could be taken up.
Right. It's going to be some sort of increase. It's hard for us. We can't know that today, but it's trying to make some increase. So, yeah.
And then what I'm saying is, I think that's very reasonable. What I'm trying to say is we could just leave ideal alone. I agree that I don't think ideal as written would be accepted, but have a stronger pragmatic that would have, it's unclear how much this would cost, but instead of having a nothing pragmatic, we have a something pragmatic, given the the tone of the stakeholder feedback, and that allows us in either case, whether ideal is accepted or pragmatic is accepted, to have a bump for the stakeholders. So I think we're trying to say the same thing. We're just kind of approaching it in slightly different ways. Does that resonate?
Yeah, I agree that the intent is the same. I think the recommendation is different. I think my pragmatic recommendation is just like the reality that the state may choose not to make any change. And again, knowing that this is a set of codes that will be reviewed next year is where I guess I have some comfort in making that set different pragmatic recommendation.
Okay. Any feedback
I could
from
support
on what
something like along that line as well. This Tim.
Tim, could you say that again? I feel like I missed part of what you said.
So looking for a resolution here.
So can members speak up? I think Megan and I are both trying to solve this in slightly different ways. Is there a preference for one or the other? Megan's recommendation is to change the ideal to be this less than 80% goes up to 80%. That will reduce the size of the ideal recommendation, the dollars associated with it, and increase the probability that it's accepted. My recommendation was to keep ideal the same and increase the pragmatic side of the recommendation on slide 21, so that in either ideal or pragmatic, if one of the two is accepted, that the stakeholders are seeing some bump. So those are kind of two options on the table. Do members have any preference between one or the other?
My preference is Ian's approach, just because I think JBC is going to be looking at pragmatic solutions. Like they probably won't even be able to tolerate ideals at this situation. So if we're actually trying to get it passed, I feel like that would be the way in. Yeah.
I agree. I agree
as well. And for those stakeholders, we all feel for you. I've been in those conversations where you're having existential discussions about what HICPA or the JBC has done, and understand we're trying to do the best we can. But like Ian pointed out earlier, we're doing something in the future. What happened earlier this year is not necessarily something we can fix. But I think that would be the way to go. And then I think an additional, more detailed rate study so that in the future we have a little bit firmer ground for everybody to make these decisions with.
Okay. So I've heard Ian's recommendation would move forward.
I'll go with Ian's recommendation.
Yeah, I think if we take the comments as a vote, then we have a majority there.
Okay.
Thank you.
I'm putting at the very bottom, just for clarity, it's exactly what I put before. I think we are approved there, and let's keep going, Brian, to the next section.
You bet. All right, maternity services, we have 4. General maternity overall benchmark here was 90%. Your recommendation was no change to the benchmark rate. They're in the target range, and then a 3% increase for those without. This is another example of no change on the benchmarks, but we have a change here on those without. Do we want to revert to the 0% increase for those without to align with the no change? Megan, that was your suggestion in the last, right?
Yeah, that was my suggestion in the last. I mean, I think we can speak to it when we get to the discussion. I don't know if there are any stakeholder comments.
There are
Public
no
comments?
comments, not for this section.
Members? We have a minor change here of $1,000 based on that 3%.
I lean towards just leaving it alone, given it's just $1,000. We can consider it more if it's a more impactful dollar amount in future services, but I lean towards we leave this the same. Are folks comfortable with this recommendation?
You mean leave our recommendation the same?
Yeah, what's on the slide would say the same. Yeah.
Agreed.
Agreed.
I agree.
Anyone feel differently?
Right, then,
All right, I think we're good to keep going.
Thank you. Next up, doula and lactation support services. The overall benchmark rate here was at 125. Your recommendation was no change, so there would be no fiscal impact. Public comments?
No public comments here.
Members?
I support.
I like it. We're good.
I do as well.
Support.
I concur.
Excellent.
Anyone feel differently? All right, let's keep going.
All right, prenatal plus, PN plus. This was at an overall benchmark ratio of 82%. Your recommendations on the ideal side were to bring all codes to 100%. That would have a total fund fiscal impact of about $58,000. On the pragmatic side, you said bring codes below 80 to 80% of the benchmark, and that would have a total impact of 1,300.
No
Public
public
comments? None. Members?
So this is a set that I lean toward the ideal recommendation. The Prenatal Plus program is a program that supports like behavioral health and nutrition supports for pregnant patients. In the state of Colorado, we have some pretty significant racial and geographic and economic disparities in our maternal health outcomes. And I think this is an important program that impacts that. And the ideal recommendation, while it's like some increase, is not a tremendous increase. And then, as I stated before, I think regardless in the report, it would be helpful to include like our ideal recommendation and still be able to see the pragmatic recommendation. So I'd say no change to the recommendation that was on the slide.
Just remind us of that, Megan, when we get to I agree with what you're saying, and just remind us at the end of today when we're selecting potential priority services. Okay, I think overall I'm supportive of this recommendation. Are members in support of the recommendation we have for Prenatal Plus?
Yes.
Yes.
Yeah, I concur.
Yes.
Excellent. Thanks,
Okay,
everybody.
we can keep going.
Next up, nurse home visitor program. Here we had at an overall benchmark ratio of just 36.9%. So for the ideal recommendation, you said 100% of hourly package analysis. They recommend that HIF review and consider adopting a comprehensive per member per month payment model and a proposed overall benchmark ratio of 100%. That recommendation and total funds impact was 4.9 million. We do have some fine print here for the PMPM model. Twice the hourly package rate was used based on the stakeholder informed assumption of an average 2 1-hour visits per month. The utilizer count month was estimated based on HICPUF's current data and data shared by Invest in Kids, and reappropriated funds were reappropriated from the CDEC through the tobacco settlement. Now, on the pragmatic side, you had 80% of the hourly package analysis, and also the same recommendation about a comprehensive per member per month model here, and a proposed overall at 80% would have a total fiscal impact of 3.9 million, or 1 million less. Public comments?
We do. We have 5 people signed up, starting with Donald Moore.
Welcome, Donald. Can you hear me? Donald, are you there?
He submitted a written comment, so he may have. It was my understanding he wasn't available today.
Okay, thank you.
Okay. Then next we have Matthew Richardson.
Matthew, there?
Yes, I am. Hello.
2
Thank you
minutes,
to members.
please.
Thank you to members of the committee for your time and thoughtful attention on this issue. My name is Matthew Richardson, and I represent Changeant, and this is the organization responsible for fidelity oversight and national stewardship of the nurse-family partnership model. The committee has already heard now how a comprehensive monthly Medicaid rate has supported program stability in other states, such as Alabama. States that have successfully adopted a comprehensive per member per month rate did not do so in isolation. They've worked through defining the billable unit, structuring rate methodology to reflect the true cost of nursing services, and preserving fidelity to the model throughout implementation. As that work's already been done elsewhere, it can be adapted to meet the needs of Colorado. Changeant's responsibility is to ensure that as NFP programs scale, which is the nurse home visiting program we're discussing here, they remain faithful to the elements that make the model effective. That nurse-family relationship, clinical protocols, visit standards that underlie its evidence base. We have supported other states through comparable Medicaid transitions, and we're prepared to bring that experience directly to this process as well. Colorado has an opportunity to build a reimbursement structure suited to its own communities, including rural and frontier areas, without starting from scratch. And we're prepared to serve as a direct technical partner to the department and to invest in kids throughout this work, offering fidelity guidance and the lessons learned from other states. So we respectfully encourage the committee to advance a recommendation for comprehensive per member per month reimbursement for NFP. Changeant is ready to support Colorado to build this model and provide a pathway for sustainable services for Medicaid members far into the future. And thank you for your time and your consideration.
Thank you, Matthew.
Thank you. Next we had Lisa Hill, but I think Allison Mosqueda is going to be speaking on her behalf.
Hi, thank you to the members of the committee for your continued partnership on this work. I am speaking on behalf of Lisa Hill, President and CEO of Investing Kids. For over 20 years, our organization has led the state's work in maternal and early childhood health, and Nurse Family Partnership, or NHVP, has been central to that mission. I want to speak today about what it will take to sustain it. Independent research shared with this committee shows NHVP reduces infant mortality by nearly half and preterm births by 15%, while lowering rates of preeclampsia and high school dropouts. The return on investment is clear. As you heard, for Colorado Medicaid, the benefit to cost ratio reaches as high as 7-to-1. State and federal savings average over $25,000 per family served by the time a child reaches adulthood. We respectfully ask the department to incorporate these figures into their fiscal impact analysis as it evaluates this recommendation. The funding source that has historically sustained NFP in Colorado, the Tobacco Master Settlement Agreement, continues to decline. A comprehensive per member per month rate is how this state will secure NFP or NHVP's future in every community, including rural and frontier areas, and we urge this committee to continue to recommend this comprehensive per member per month reimbursement rate. Thank you.
Thank you.
Thank you. Next we have Christy Reeves.
Christy,
Hi, everyone.
2 minutes.
Thanks to the members of the committee for the opportunity to speak today. My name is Christy Reeves, and I serve as the nurse supervisor for the Nurse Family Partnership Program here at Adams County Health Department. I want to speak plainly about what this program means for the families we serve. Adams County NFP serves more than 200 families a month. Every one of those families receives a trained nurse who conducts ongoing assessments of pregnancy health, screens for maternal depression and domestic violence, monitors fetal and infant development, and connects parents to housing, food, and behavioral health resources long before those needs become emergencies. This is comprehensive, relationship-based nursing care delivered in the home for over 2 years with each family. I've watched our nurses catch preeclampsia before it became a hospitalization. I've watched them recognize signs of postpartum depression that no one else in that mother's life had noticed. That is prevention in its truest form. Care delivered early enough to change an outcome, not just respond to a crisis. Every one of those interventions represents real savings to our health and social systems. Avoided emergency care, avoided NICU stays, avoided child welfare involvement, avoided special education costs down the road. None of that happens without a nurse at the door. And keeping that nurse there month after month requires financing that reflects what this work actually costs to deliver. A comprehensive PMPM rate would give our agency the stability to keep serving those 200 plus families and to keep reaching more of them for years to come, not just this budget cycle. We urge this committee to support this recommendation. Thank you.
Thank you.
Thank you, Christy. And we'll go back to Allison Mosqueda for your own comment.
Hi, thank you again to the Mprrac and HICPAF for the opportunity to speak today. So my name is Allison Mosqueda, and I am also representing Investing Kids as the Director of Community Health Nursing. We ask Mprrac to continue to sustain its recommendation that HICPAF adopt this comprehensive PMPM rate. This structure supports predictable budget planning for agencies. It gives the department a clear picture of the program's fiscal impact moving forward, and it removes any incentive to increase visit frequency just to generate payments. We continue to reiterate that the current system is not sustainable. With fee-for-service and targeted case management billing, nurse home visitor program sites only recover less than 5% of current program costs, and this puts a heavy administrative burden on nursing time. A comprehensive rate would instead reflect the full scope of what NFP nurses do, direct care, travel, and administrative work, while preserving the flexibility nurses need to deliver individualized care with fidelity to the model. As we have shared the return on investment data with the committee, and a reminder that for every every dollar invested receives $7.90 in return, and more than $25,000 per enrolled family. This is driven by reduced ER use, stronger primary care connections, and consistent follow-up for both caregivers and babies. This structure also supports the department and the RAIs in meeting KPIs such as depression screenings, prenatal and postpartum care, and well child visits. With our tobacco master settlement funding declining, a comprehensive per member per month rate offers a genuine path to sustainability, where NFP may be the only consistent nurse-led support, especially in our rural and frontier communities. We respectfully ask this committee to continue to recommend this PMPM structure for the nurse home visitor program. Thank you.
Thank you.
No more public comments.
Members?
Thank you all for the comments. Any member comments here?
No, I just appreciate the stakeholders, and they gave us similar presentations when we were doing our rate review. So thank you. I think they should end up in our recommendations.
Yeah, and again, I see this as a priority population. I feel comfortable with recommending our, like, we're making our pragmatic recommendation. You know, understanding it has a fiscal impact, but I think this is definitely an area that we need to prioritize, and that having a comprehensive reimbursement is ultimately going to be the route to go.
I agree with you, Megan, and that follows a lot of the decisions or ideas that we had in the last meeting about prioritizing certain preventative care models.
Return on investment on these dollars is definitely worth it.
Yeah.
I agree with everything that was just said. And so I believe this is already reflected in our recommendation. And so we would just continue the same recommendation. Are members comfortable with that?
Yes.
Yep.
Yeah. I think so. But again, I'm just, as I went through these, I sort of said, like, I feel comfortable with the, pragmatic versus the ideal. And so I just think that there are some of these that we may need to say which side we're leaning toward. And again, while I support the comprehensive model, I feel like I do still lean toward the pragmatic recommendation in this case, however we want to reflect that.
Megan, I really appreciate it. You've presented to the JBC before, so you're helping us think about what they need to hear to make their decisions, right? That's what you're holding in mind. Yeah.
Yeah.
Okay.
I guess my how I'm imagining is probably our pragmatic recommendations will be used as a starting point, and then we should pick a subset for ideal to really emphasize, and maybe even within pragmatic also emphasize. And so that's how I'm imagining this last conversation today would go, would be to really like emphasize either pragmatic or ideal to make sure that those carry more weight with the JBC.
Okay.
Okay, I think we have agreement here. Any opposed to our recommendation? All right, we can keep going.
Excellent. We have abortion services next. One recommendation, where we were 132% of benchmark. And the one recommendation was to bring 59852 up to 80% of the benchmark. And a policy recommendation to explore modifier 22 or others to adapt reimbursement for case complexity. The proposed overall benchmark at 132. So bringing that up to 80% actually would have no fiscal impact, it appears. Public comments?
Is there a reason there's not a fiscal impact for that? It seems odd to me.
Kim?
Yeah, thanks, Ian. That code has no utilization. It hasn't been utilized in a while. So
Okay. Thank you. That's helpful. Thanks.
We do not have any public comments.
Members?
I support.
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 Support. Good.
I support as well. Any opposed to our recommendation? All right,
Very good.
I think we can keep going.
Next up, we have pediatric behavioral therapy. Again, we were at 92% overall versus our benchmarks. On the ideal here, we've said raise codes below 100% of the other states' marks benchmarks to 100% and increase the rates for those without by 3%. That would have a fiscal impact. The first would have a fiscal impact of about 23.4 million, and then 10,000 would be the increase on those without. That gets you to 23.4 million. On the pragmatic side, we've said keep the codes with benchmarks the same and increase the rates for those codes without a benchmark by 3% for inflation. That would have a fiscal impact of about $9,700. We have policy recommendation here, cover that 97156 at 100% of the other states' benchmark. That would have a $28.3 million fiscal impact. Then we have cover 97156 and 157 at 80% for a pragmatic recommendation that would reduce the impact, fiscal impact by $2 million approximately to 26.1. Any public comments?
Yes, we have 4 people signed up, starting with Ken Wynn.
You there, Ken?
Yes, thank you so much. I first want to
please.
say I've participated in a number of these over the years, and I so appreciate the role you guys play and the partnership that Mprrac has had with the ABA community. So I appreciate you all. The comments I have to make. I've been involved since the beginning when the PBT therapy program started. It has had life-changing effects on the community. It has also been significantly effective in reducing costs, including hospitalizations, residential care, both medical and non-medical costs. So it is an important program, and we need to keep this program alive. We've seen how fragile it can be. We've seen over the years a reduction in providers and significant issues on network adequacy because of the rate. So it's an important, highly effective and important program, and we need to make sure that we're keeping those benchmarks. My recommendation is to keep the benchmarks that we have, but also it includes the 3% for the ones without benchmarks, because there's a little bit of a disingenuous approach to the benchmarks. I also highly recommend, I was super excited to see that we're using 97156 and 57. If there was one thing I would recommend beyond anything else is to include those rates and have those benchmarks to the other states. We are behind the other states. I'm licensed in Texas. I provide services in Texas, and we've done 5.6 and 5.7 for years there. It is really important to get 5.6 and 5.7. And of all the cost saving measures, that's one of the most important, because those allow us to provide supports to parents and caregivers. And we need to focus more on those parents and those caregivers. And I think that's one way that we will be able to do that. And I think we need to be compared with other states, because we're actually behind other states in doing those kinds of things. So my recommendation is to get 5.7 and 5.6 into our system and get it up to the benchmarks with other states, and to increase the 3% for both benchmarks and non-benchmarks.
Thank you, Ken.
I apologize if I mispronounced this name. I believe it's Svi. TZVI. I don't see them listed, so they might not be in attendance.
Okay.
Okay. Next, we have Will Martin.
Will, you there?
I am.
Go ahead, 2 minutes.
Awesome. Thank you. And first, I want to thank both the Mprrac committee and HICPUF. I realize both groups are in a difficult situation here with a tight budget cycle, and appreciate the work that both groups are putting into this important process. I'm here representing the Colorado Association for Behavior Analysis. I agree with many of the other comments that have been made already. I think rates are critical for this therapy to be available to children. Intervening early is known to save costs over time, and this is a very, very important area for us to invest in. I would really like to spend some time talking about 97156 and 97157. As Ken mentioned, these are common codes that are available in just about every other state except for Colorado. If we look at the CMS toolkit that was recently released for applied behavior analysis and the OIG report, both really emphasize the importance of parent and caregiver engagement. And right now, without these codes, we don't actually have the opportunity to maximize that as therapy providers. So it's also a way we can differentiate, in my opinion, high quality providers from low quality providers, and would be a way that you could look at some parent and caregiver engagement as an indicator of quality in terms of a program as well. So wanted to thank the department and the Mprrac committee for their time and work on this, and really emphasize the importance of 97156 and 97157. And please reference both the OIG report and the CMS toolkit for some information about why those codes can be transformative for children and families. And thank you very much for the time.
Thank you, Will.
Thank you, Will. And lastly, we have JJ Gorsuch.
AJ?
Hi, everybody, and thank you for your time and dedication to all of these efforts. It's very important to the community. We appreciate it. I do want to echo both Will's and Ken's statements. I want to add one other thing on 97156, that the economic impact actually may not be as impactful as modeled here. There has been informal but specific advice from the department at times to include parent coaching in 97155 with the client present, which is something that I know providers have done, and it's less than ideal in many ways. it's hard to coach with the client present with kids climbing over you, for one. But for two, it is, it's just not a proper use of the code. And it would be a lot better for, especially the reasons Will mentioned, to be able to track these things separately as a monitor of the quality of care and as a reducer of overall costs, as Ken outlined. I also just wanted to, but anyway, the reason I think it'll be less of an impact is because some of this coaching is already happening just under a different code. Lastly, I just wanted to suggest that the pragmatic, and I'm not sure I understand this, but the pragmatic recommendation should probably include a 3% increase for all codes, not just those without benchmarks. Um, it still won't keep up with inflationary pressures that we face, but I'm not sure why it's only recommending it for those without benchmarks, since there is no other increase in the pragmatic recommendation. Thank you for your consideration. Have a great day.
Thanks, JJ.
Thank you. No more public comments.
Members?
I want to echo what JJ said. I think that the impact for opening up the 5.6 and 5.7 codes is grossly overstated here. And I agree. Informally, we've been applying these practices under the 5.5 code. So 5.8 or 5.6 and 5.7 being reimbursed at lower rates would actually probably decrease the amount of funding needed for these. Not to mention that we have to provide parent and caregiver training in our recommendations and our prior authorizations. So if we're requiring that to be part of the model that we're administering, then why aren't we opening up these codes for that specific practice?
Manisha?
I want to echo the stakeholder comment about 3% increase to codes with benchmark. Also, going back to the conversation that we were having when we were talking about NEMT, not making any changes, JBC has that option even without us giving them this option. So even if we don't say that don't make any change, if they don't want to make any change, they will do that. Or if they want to cut down further, they would do that. But from our recommendation, I would like that 3% inflation increase even on the codes with benchmark ratios.
Megan?
I guess just to respond first to the issue around codes without benchmark, I think we need to decide which route we're going to go. Historically, our process has been the 3% increase exclusively on codes that, have no benchmark. And so that's sort of where I feel like if we're making the recommendation of no change, that even where it was small on the NEMT, that just making the no increase across the board makes the most sense. If that's the sort of general sentiment, making a 3% increase across the board, we also is something we just don't have the fiscal impact of, and I feel a little bit uncomfortable making that as an alternative recommendation. I feel like maybe something to discuss in November if we want to think about making a change to how we approach that. And then I feel like this is a set of codes where I felt most comfortable with our pragmatic recommendation for the codes that are currently reimbursed. And then I'm struggling a little bit with the policy recommendation given the degree of potential fiscal impact in either case. And I wonder whether, if we said can we just reimburse this at 30 or 40%, which is an extremely low rate, but might allow for some information about how often those codes are used. I don't have a great sense of what the impact would be and whether that's worth it at all to the folks that are providing those services. But I think just to, again, allow some information gathering and understanding that, I mean, I at least don't feel super comfortable with the, 20 plus $1 million impact that it is to even add those at 80%.
I think Kim, you were the one who did this analysis last time, and I know we talked about it last time. Can you just again remind us for slide 43 how the numbers are calculated?
Yeah, so for 97156, originally we were for the June meeting, I think we went over PPT. We are looking at using 35% of the utilization from 97155. But I know the providers during that meeting did speak about like, oh, how did you calculate this? So we looked at, in this case, if for every, on average, the weekly member count for 97153, the normal therapy hours. So if we look at the average weekly utilizers of that code from fiscal year 25, and we assume that they're getting 2 hours per member per week. And we looked at 45 weeks to assume families go on vacation, they get sick, things happen rather than the full 52 weeks. So with those assumptions, this code reimbursed at 100% of the other benchmark would add 28 million, would cost $28 million, right around there, assuming 2 hours per member per week.
Did
Okay.
that take out the time from the 97155 code then?
No,
I think that's where the issue is.
It's just that.
I think that's where the issue is because it's being utilized in that way. So families are coming in while the BCBAs are administering treatment, and the BCBAs are basically talking about what they're doing and externalizing that process to the family members while they're instructing the RBTs. This is the informal process that we sort of have to follow now. So if we're not calculating the time that we would take off of 97155 and putting in the 97153, then we're not actually doing that exchange, not to mention the fact that the only accrediting bodies that are available to us won't even qualify Colorado recipients for quality care oversight because we don't have these codes open. There are no ASQ members from Colorado because we don't have these codes available to us. So I think there's two pieces here. One, it hits the quality assurance piece, but secondly, the accounting isn't taking out the 97155 and putting in the 97156. So it's just adding to it rather than taking away from it.
And unfortunately, we don't have that data for how much of 97155 is being used for this. And we don't have access, so we can't really calculate that. We don't have a good way to calculate that in. This is just this code on its own, what it would cost if it was utilized in this way. Like similar to the some other programs, it's hard to build in these potential cost savings into this fiscal impact. We can just look at at a very, a bit more of a basic level. Like if we're utilizing 2 hours per week at this rate with the number of members we have, this is what this single code would look like. So yeah, I wish it'd be nice to have, a bit more data to measure that all in, but we don't have that at this time.
So I have a couple thoughts. One, I just want to make sure the committee understood what 97156 is. This is the family treatment guidance code. It's basically caregiver coaching. So if a child comes to a program, they're receiving direct intervention. The 97156 allows the clinical team to meet with the parent without the child present and coach the parent skills that we're working on in a indirect therapy that allows the parent to then carry those out into the home or community setting. And it basically is a force multiplier for the impact that can come from services. I think Colorado may be the only state that doesn't cover it. So clinically, it's very, very important, is considered basically just core to quality services, and we don't cover it in the Medicaid program. So I think like the clinical need for this is very, very strong. My second thought is like I'm nervous on this recommendation as written. Having done this for a couple years now, I'm worried around JBC response to a $28 million recommendation. And furthermore, I agree with Nicole and others that I'm not sure it's accurate. And I think it could harm rather than help to have this recommendation as written. And so I'm thinking out loud on the spot, but I'm trying to think through, is there some way to kind of keep the spirit but change the recommendation, such as, explore cost-effective ways to deliver family treatment guidance and collaborate with stakeholders on a data model around it, where we're sort of capturing the clinical spirit of the purpose of this while not recommending $28 million, which I don't think anyone would recommend. And I'm flexible on the details, but that's sort of what I'm trying to think through live with the committee, and I'm curious if others have thoughts on that.
Megan,
I think Manisha was first.
Anisha?
Based on what Nicole was saying, and again, not trying to skew the numbers here, but I also saw some stakeholders commenting that these numbers are based on 2 hours per week, and many stakeholders are saying even 1 hour per week is enough. So that literally cuts it down to half right there.
Megan?
Yeah, and I guess I'm having a similar feeling to what Ian is feeling. My recommendation about like putting it out there at a lower percentage was with a similar intent to try and get those codes used and see what the utilization was. I did see the comment back that, if it was sort of at a super low rate, that they just wouldn't be used. It sounds like these services are sort of indirectly being provided and being billed under a different code. I feel like I would say changing the policy recommendation to something like finding a method to track when these codes should be used, but a different code is being used, in order just to gather that information. I don't feel comfortable at this point making a recommendation that they should be covered, given that this is the information that we have for now. But I do think that there's a strong need to understand how often these codes should be being used, but something else is being coded.
Tim?
So my thought is based on that recommendation. There's always a fiscal note, Ryan. If HCPF were to go back in and analyze this and the utilization of these additional codes, what do you think the fiscal note would be to do that?
Yeah, I mean, I think it would have to be a period of time, say, where like the folks that provide these services would bill as they currently are, but somehow like ghost bill what it should be or what it might ideally be if they were using these services.
But it would still take staff time to do that and to do the analysis of it. And what would that fiscal note be?
Langley?
November 1st, we have to submit the report to the JBC and the governor office. And our November meetings happened after that day. So every decision discussion should be public atmosphere. So personally, I suggest that maybe you can change your policy recommendation to be a little bit vague language. Don't attach the fiscal impact to reduce the confusion and the worry because you think the number is too high.
So I building off of what you're saying, what I was saying earlier, I put something in the chat here. How would members feel about something like this where we're keeping the spirit of it, but not attaching a $28 million budget impact? And that would allow us to take this offline. Stakeholders can work with Ling Ling and the team on refining the analysis. It's written down that we believe as a committee that this is important, but we're not attaching a multi-million-dollar number against it.
I think I can feel comfortable with that. But just to clarify, are we only talking about the 97156 because the pragmatic also includes 97157, and is it both of those that?
It's both. I think 97156 is more common, which is why you're hearing us, the community,
Okay.
talk about it. But I think it would be both.
Yeah, I think if we're like recommending exploring cost-effective approaches, I would just include both, even understanding that the 57 is a lower utilized code.
Basically, 5.6 is one-on-one with one family, and 5.7 has multiple families present. And the one-on-one is much more common, but both do occur.
We do have a proposal in the chat.
Are members comfortable with what I put here?
I am.
I am as well.
I have a question with this one, and I love this approach. Thank you, Ling Ling, and thank you, Ian, for this recommendation. But is JBC going to be okay with us making a recommendation without attaching the fiscal impact? Are they not going to ask on the spot about it?
This is for policy recommendation. That's totally fine. That's the normal thing.
Okay.
Yep.
Nicole, do you have any thoughts on this?
No, I think I appreciate what we're trying to do here.
Okay.
Great. Looks like we have agreement.
Let's let Ken, do you want to speak?
Yeah, I appreciate the conversation. I just want to highlight what Josh had put in there. I think that's a good approach. But I just want to emphasize that the 97157 is an even better cost reduction because it allows for group training. I do a lot of group training, and I have to find other sources of funding, which ultimately comes from Medicaid. So this is funded in different ways. It just brings it into more highlighted under this program. I think it ultimately will reduce costs. The group training is an even better cost reduction because, as I said, it allows. That's what 5.7 is. It allows for group training. So, however we do this, I think it's just important to get it done. It's so important for Coloradans.
Megan, thank you, Megan, I was thinking back to what you were saying about like having maybe a 40 or 30% rate and adding that in. And I wonder, I think we'll just see more people continuing to kind of go the status quo and what they've been doing so far. And that's my worry about that being even an effective use of our time and resources.
Yeah, and I think I saw that from somebody in the comments as well. So again, I feel comfortable with this like vague. We see the importance of these services, and there needs to be some study into what the impact would be of using them over whatever makeshift route is being used right now.
Yeah.
And I think the suggestion from Josh in the chat is a good idea, that you like keep it within the utilization of 97155, so you're not actually adding incremental costs. It's just you can use your 5.5 units for 5.5 or 5.6. But I think that's sort of the point of what I'm putting in the chat here is like this is the last time we will have before HICPUF writes the report. And so we have 3 to 5 more minutes on this topic, and something vague like this will allow us to continue that discussion offline, collaborate with HICPUF and with the JBC to find cost-effective ways to reach this aim that we all support. So it allows that discussion to continue. I worry that as written here, this will stop discussion on the matter because it will be seen as too expensive.
Good.
Okay.
Okay.
I think are there any dissenters to this updated policy recommendation for 43 or our existing recommendation for slide 42? I think on the if we go back, okay, we went deep on slide 43. Can we go back to slide 42? I think there was this question that Megan, you alluded to earlier around the pragmatic and keeping the codes the same, basically the top right bullet here versus 3% for everything. I think I think what we do here, we would have to be consistent across all services. Like we shouldn't just, if we were to do that here, we should do it for every service because I think, or at least every service that we've done this keep codes the same. And so it will have a multiplier across basically, I don't know how many service lines, but many. I think we would need to be consistent across all. And I don't know, any comments from committee members on if we how far we want to go down that path.
I think I lost internet connection when we were talking about this the last time. Even making a pragmatic recommendation of no change, I feel this should not even be an option from the committee. JBC can land on this option, but I would say a 3% inflation should be added to the codes with benchmark ratio as well. As a committee, if we recommend this, and then if JBC decides to not make any changes or cut down even more, they do not need a recommendation from us to be able to do that. But at least recommending that we do need these inflation adjustments is a minimum.
Langley?
I want to mention if you want to have a 3% of the increase for all PPT code, that will lead to multi-million dollar fiscal impact.
Yeah. And I want to give us just a quick time check. We have a number of other services to move to, so let's see if we can wrap up a recommendation here.
Ling, my internet cut out. You said how many $1 million would be the 3% increase?
I don't have the number, but my memory told me, yeah, because I remember on October 2025, the governor executive order cut 5% for PPT. It's multiple $1 million impact. So I remember
multiple $1 million.
Yeah,
Very roughly, I think it was around like 250 million of spending. So it would be 3% of 250 million, which would be that's 7.5 million.
Yeah.
So that's very rough, very rough. I'm doing mental math in my head, but it's like probably like $5 to $10 million, something like that.
Yes, you are correct. If you apply to PPT theoretically for consistency, you should apply to all services.
And that it's not just PBT, that is like all services is going to be I don't know what the total sum is here, but it's going to be 3%, maybe not across everything, because not all of our pragmatic recommendations were like this, but it's probably a big number.
Yes.
Yeah, and I think for me, the pragmatic recommendation was in part to help highlight where we feel like things are sitting in a range that's kind of reasonable right now, but if we were in an ideal situation, maybe would want to increase. And so I feel comfortable if our recommendation is just no change, even knowing that the JBC can always make that recommendation. I think there were some areas where we said, like, these are priorities. They're either setting like much lower, like in an unacceptably low as compared to benchmark place, that we think that they're like really problematic. And so we need to, even the pragmatic recommendation has some degree of an increase. And then there are some areas where it was like, we can make no change here. And I think in this code set, I feel comfortable if we said, pragmatic zero increase, but the issue really is that we have a set of codes that aren't being reimbursed right now, and that is what we need to address.
And I think they're saying we're not even going to get to address that this year, that there has to be a physical impact study because the numbers that we're getting aren't correct anyways. They're not taking into account the way that the services are being applied and utilized in alternative ways. I think also one of the things I want to just, I know we're short on time, but to take it back, why we were talking about the 3% increase too, is because there's a new set of recommendations everyone's going to have to get within PBT has to get credentialed and licensed this year. And that was another piece of why we were looking at an increase specific to this field, because that impact is going to be huge, going through all of the process of getting everyone their background checks done at like these higher federal levels. And like I have 125 employees, like that's not small. And so I think, there were serious policy changes associated with PBT from the state level, which sort of, I appreciate wanting to like apply everything the same too, but we also know that every program has its own things that are also going on behind the scenes and changes it, and that makes it tough.
Yeah, I mean, I think it does make it really tough. We had the extended conversation with the NEMT services about their very dire situation, and so I think that's just where we need to be consistent across sets of codes. There's a lot that is really challenging in our current system, and so just understanding that, I do think it's important to keep some consistency.
My perspective is that it's going to be hard to add this 3% across this entire data pack. It's going to lead to probably tens to hundreds of $1 millions of spending on the pragmatic side that is just going to be ignored. And so my perspective is we leave this the same. I agree with the spirit of what the commenters are saying and that we should do it, but we leave that to advocacy with the JBC to push them. I don't think they'll do the ideal no matter what is my perspective, but push them towards the ideal, which could be the outcome that you all are describing. And that's more an advocacy element than an Mprrac element, so that we can be consistent across every service line here. So I would say for that reason, we keep it the same. This recommendation the same as written on this slide.
So this is Tim. Are you saying we keep the pragmatic recommendation the way it is without the 3%? Because if we give the 3% in this one, do we have to consider 3% in the others?
No, I'm saying as written, this slide does not change whatsoever. What is written on this slide stays the same. There was this proposal to change the first right bullet on this, and I'm saying we do not do that, because I think if we do that, we have to do it everywhere, and I think that will be prohibitively expensive and will so that's what I'm trying to say.
So you're saying keep the 3% increase in the pragmatic recommendation.
That is what's being said right now. Again, I think we'll need to make the decision in either way. It's a little tough, the sequence of these slides, because the fiscal impact of that 3% when we're making no change to other codes kind of increases as we go through these slides. So as we get to the dental service, I think it was dental services, where we said the same thing, like make no change to the codes with benchmark, but do a 3% increase for codes without, and there's like a slightly higher impact where it was like almost nothing for NEMT services. It's a little bit more here, and then it's like, a factor of 5 or 10 on those dental services. So I think whichever way we decide to go, we need to do the same thing. And I feel generally comfortable whichever way we decide to go, whether we make the 3% increase on codes without benchmark, or whether we just say no increase means no increase.
Ling?
Yeah, it echoed to in the beginning of the note for the consistency. Yeah, you can keep what you have now, or remove the 3% increase for pragmatic recommendation. Like make everything clean, no change to all code for each service, for the whole service.
Okay, so we're looking for a proposal. Ian, you mentioned keep this the same.
I feel comfortable with the keeping it the same.
I feel comfortable with going Megan's route too, where we're talking about no change as well. I think the biggest issue that I'm facing with this is opening up those 5.6 and 5.7 codes. So if I have to choose what it is I want, then that's what I want.
I support you guys as this is your industry. Yeah.
Okay.
So I'm going to try and recap. We are saying we will keep this recommendation on slide 42 the same, and then we will update the slide 43 recommendation to focus on 97156 and 97157 without this cost estimate, which is meant to be additional stakeholder engagement and additional data analysis to find cost-effective ways to cover 97156 and 97157, which we all think are important and may be over costed here on this slide. That would be our final recommendation.
Correct.
Yes.
All in favor? Anyone opposed to that recommendation? Okay.
Perfect. Ling Ling?
Yeah, for your revised recommendation for the policy, probably the annual report, we will take off the overcost words. Because if you put there, JPC will ask why you say it's overcost. What is the cost you provided? Like a rebel whole peak. So we will just say we will do more research and collaboration. Yeah.
Yes, that would be great.
Okay. Thank you.
Thank you.
Okay. Anesthesia. I would propose we work our way through anesthesia and then take a lunch break.
That sounds good.
Okay. Let's dive in. We had an 84% benchmark before over the last fiscal, and our recommendation out of July was no change to remain at 84%. That would have no fiscal impact. Public comments.
Yes, we have 3, starting with Kathy Rasmussen.
Kathy, you there?
Here. Thank you, everybody. Can you hear me?
Yep, 2 minutes, please.
Wonderful. Thank you. My name is Kathy Rasmussen, and I'm with a private practice, physician anesthesia services based out of Wheat Ridge. It is our understanding that the Mprrac role is to look at the costs for care and not doing the JBC work of actually making those decisions, but we are not covering our costs. We understand the goal is to have Medicaid at 85% of the Medicare fee schedule. However, the Colorado Medicare fee schedule has not seen an increase in the past 20 years. There has been no adjustment for the cost of living, let alone fair market value. The continued use of a percentage of the Medicare fee schedule as the primary benchmark is harmful to single specialty private anesthesia practices, particularly as the proportion of patients covered by government-sponsored programs continues to increase. Reimbursement that does not adequately account for the actual cost of providing anesthesia services, which ultimately affects practice sustainability and patient access. Can you please provide comparative data demonstrating the reimbursement disparity between anesthesia and other closely related specialties such as surgery? Specifically, it would be helpful to compare Medicaid reimbursement as a percentage of Medicare for representative anesthesia and surgical CPT codes, as well as the historical changes in those rates over time. We believe this data will provide a more complete picture of the impact of using 85% of Medicare as the benchmark when anesthesia is processed differently than surgical counterparts and help determine whether that methodology appropriately reflects the resources, costs, and complexity involved in providing anesthesia care.
Thank you.
Thank you for your time.
Okay, next we have Catherine Heck.
Catherine, you there? Catherine Heck?
I don't see her on the attendance list.
Okay.
We will move on to our last one, which is Melissa Brooks Peterson.
Melissa, are you there?
I am now that I unmuted. Hi, everybody.
All
Okay,
right, 2 minutes, please.
between I think you and lunch, so here we go. I'm Melissa Brooks Peterson, pediatric anesthesiologist. I was at Children's for 15 years. I'm now kind of all over the place. Definitely a dedicated Colorado pediatric anesthesiologist and Colorado native. So, what Colorado does with healthcare is very important to me and my kids and my husband and all of my colleagues. I come mostly representing the CSA today, though I am a pretty vocal mom and patient. We appreciate the opportunity to provide comments to Mprrac and also really appreciate the HCPF staff has spent a lot of time meeting with us as the CSA to explain the methodology used to evaluate Medicaid provider rates. A few things I want to address about that. So we currently, the HCPF considers Medicaid rates in comparison to Medicare reimbursement and reviews provider participation to determine whether those rates are creating barriers to access. And we, as the CSA, and I understand the reasoning behind that methodology, we really respectfully believe and feel strongly that these measures don't adequately reflect the unique circumstances of how anesthesia care comes about in the state of Colorado, especially for pediatric patients. So when kids need surgery, trauma care, MRIs, CT scans, diagnostic procedures, or treatment for simple, serious, and complex medical conditions, obviously anesthesiology is an essential part of their care. You're not going to take a kid into the hospital and be able to really do anything without anesthesia. This happens on nights, weekends, daytimes, emergencies, routine, everything, 24/7, 365. And kids with medical needs occasionally require highly specialized anesthesia expertise that can't just like move about the country, move about the world. That's actually where I fall in, but for all children requiring surgery, trauma care, everything. So
We're at 2 minutes, Melissa.
unfortunately, pardon?
We're at 2 minutes. We can wrap up, please.
So using Medicare as the primary benchmark for Medicaid anesthesia rates begins with a reimbursement system that in 2020, reimbursement for anesthesia services in the same operating room as a surgeon getting 80% of commercial rates, that's anesthesiologist getting 27% of those commercial rates. Where we sit right now and what we're
Melissa, you
asking,
need to wrap up. We're at 2
Okay.
minutes and 30 seconds.
So what we're asking for is the 84% benchmark to be returned to 100%, which is where it belongs. We understand that that's a big ask. We're already running way low.
Thanks, Melissa.
Yep.
Thank you. No more public comment.
Members?
Just a procedural question. This is Kate. Did we have stakeholders at our previous meeting when we were discussing the recommendations?
Yes, we did.
Oh, we did. Okay. Okay. All right. Thanks.
Yeah, and I think the challenge with this set of codes is that there was the adjustment for all codes that are benchmarked to Medicare to reduce to 85%. And given that that's sort of our strongest methodology, it felt challenging to recommend something different for this set of codes when, again, every other code that's benchmarked to Medicare got set to 85%. And then as we, moved to the later services, surgical services that we're reviewing this time around, I think we just tried to remain consistent. Again, there's another area where we're seeing that the dramatic reductions that happened are having a tremendous impact. I think just trying to use some sort of regular methodology has been kind of our approach. And so, yeah, as like difficult as it is, I sort of feel okay with sticking with the recommendation that we've made.
Can we go back to the recommendation slide just so I can see it? That would be great.
Just to build off of what Megan is saying, because I think some commenters may not have been here last time. When there is a Medicare benchmark service where we use Medicare as the benchmark, I believe, Kevin, correct me if I'm wrong, I believe that's in the statute itself that we have to use Medicare as the benchmark, and that's our common practice, regardless, where 80 to 100% of the Medicare benchmark is what we basically always recommend for a Medicare benchmark service. Now, if there are specific things within anesthesia that, should make us adjust that consideration here, I think that is something that is a good discussion point with the department and with the JBC, but like this is pretty standard for what we would use for a Medicare benchmark service. I mean, I think the thing that we don't have here that we could consider is we don't have an ideal and pragmatic recommendation. So we could have what's here be the pragmatic recommendation, and we could consider some ideal. That was the only thing that came to mind for me.
Yes, the statute just says that we need to make comparison to Medicare, and it actually says private insurance. Unfortunately, we just rarely have that information, or more than like 1 out of 100 data points.
Yeah, I just want to address the stakeholder just really quickly that, yeah, if the Medicare rate hasn't been reviewed in 20 years, by statute, we have to use the rate that Medicare gives us. So as an advocate, it might be worth advocating at the CMS level, which I know is not the answer you want, but if that rate is 20% of physicians, then that does seem to be, and hasn't been reviewed in 20 years, that seems to be a serious problem from CMS standpoint, CMS being the Medicare.
So
in terms of, yeah, go ahead, Megan.
Just to that, okay, like this is something that has been reviewed, and there was a sort of shift to how anesthesia services are modeled within Medicare.
Oh, okay,
I think that
that's
was
great.
back in 2020-ish.
Okay. Yeah, but then in terms of recommendations, if there is a Medicare rate, that's what we benchmark. And when there isn't a Medicare rate, we benchmark to other Medicaid states. So yeah, that's our process. Sorry, Ling Ling.
Yeah, Ling Ling.
Yeah, for the anesthesia provider, we would like if you have a public accessible commercial rates for anesthesia, we would like to see. And for the civic, their data need extra effort to pull, and we need an additional contract. And they say, can do this fall. We say, okay, that's too late. November 1st, we need to finalize the report. That's the issue.
Yeah, just to follow up with Ling Ling and other stakeholder matters in this case, if stakeholders have that data available, that private data, HCPF has utilized it before and has been grateful for it. So it's been super helpful. Yeah.
Yeah.
As long as there's not something stipulating in your contract that you can't share it. That I think that's that has to be stated out loud.
Yes, we reach out to commercial insurance company like Denver Health or Rocky. They usually not willing to share any private commercial rates due to the contract confident privacy issue. Yeah. And the TRICARE use the Medicare rates 100%.
Yeah, so I think if we were wanting to make a different recommendation for the sake of consistency, the codes that were also benchmarked to Medicare that we'll look at later, we said, bring any codes below 80% up to 80%, and those like over 100% down to 100% as an ideal recommendation. And then for a pragmatic recommendation, bringing codes that are over 85% down to 85%. The thing that was unique about this category was that like every codes sat at the same, or the whole service lines sat at the same percentage, which was close to 85%. And so that's where we kind of landed on this no change. So, I think the only other kind of alternative recommendation that would be like, these drifted down a little bit, bring them up to 85%. But I don't know that that would have the meaningful impact that, we're hearing from stakeholders feels like it's needed.
Kim?
Megan, hold on, let me try to get my video to work again. Almost every single code is right at around 84 and some change. There is one code that is below 80%, and that's the 01996. It's the only code that we have like a slightly different approach than Medicare has for reimbursement. So there is one code below 80%. And it's not super heavily utilized.
Right. I mean, so if we wanted to make ourselves feel better and have the recommendations look like identical for these sets of services that are compared to Medicare, I think we could change the wording to what we'll, see later in the surgical services, but I don't think it has the like meaningful sort of impact that stakeholders are looking for.
Yes.
Would a review, oh, sorry, go ahead. Would a review, kind of like what we recommended for PBT in the way that the analysis is given, would that be a helpful recommendation pragmatically?
Not really in this case because Medicare exists already. So we have to follow the statute. Yeah.
I mean, the only thing I would say is there is range within 80 to 100%, and it was set at 80, roughly 85%. I agree it's drifted down. So we could have a recommendation to evaluate whether that is the appropriate sitting point between 80 and 100%. It was sort of arbitrarily set at 85%. And so that could be a policy recommendation, Nicole, to say, evaluate with stakeholders the appropriate point in between 80 to 100% based off of additional data analysis and stakeholder feedback.
I think my discomfort with that, like unless we truly believe that the Medicare methodology is flawed, that it would be ideal for all codes that are compared to Medicare to be at a rate that's higher than 85%. There's, plenty of things that are challenging about the Medicare fee schedule, and relative reimbursement has drifted down over the past 20 or 30 years because it is a fixed pot of money. And so the amount that is able to be allocated to each individual code drifts down the more things that we're paying for. But I do have a challenge with calling out a specific set of services that are valued based on Medicare, just understanding that it really has broad effects across all of those codes across multiple categories.
I think Ian's recommendation is the only room we have within this committee is to go. Ian, did you say 100% or something? Or you just said more than 80 essentially, right?
I'm trying to say something slightly different. I'm actually not recommending to change this recommendation. I'm comfortable with this recommendation. What I'm saying for anesthesia and frankly for other services, there was an arbitrary cut to 85% of Medicare. 85% didn't come from anywhere. That was, I believe, the governor. I'm not sure who selected 85%. Someone selected 85%. For Medicare benchmark services, we do stay between 80 and 100%, but every single service was set at 85%. And that was somewhat arbitrary. And it would be a reasonable step for us to recommend for anesthesia and for other services to evaluate where within 80 to 100% should it sit, rather than a policy decision that was made at 85% for everything. I think that's a reasonable thing to propose, not just for anesthesia, but for everyone.
I appreciate that, Ian. Yeah, I like that recommendation. Thank you.
Yeah, I mean,
proposal?
I feel like that to me sounds like something that we sort of discuss at the end. Because yes, I would feel comfortable making a statement that that arbitrary adjustment, 85%, is problematic and not something that, we necessarily support, and that there probably needs to be more look into that. But I don't know that I would put that label or policy recommendation specifically under this category.
Tim?
And thank you. One of the perspectives I want to give the group too, as far as being the longest running Mprrac member on this committee, is that going back to the very beginning, some of the priorities were obviously we don't want providers to lose money providing care to Medicaid patients, but where the 80% generally came from was I can't remember now where that 80% came from, or why we settled on the 80%. But generally speaking, we didn't want any provider to be below 80% of the Medicare benchmark when there was a benchmark of Medicare. And when we were consistent amongst the various payers back then, or the various service lines back then, we generally made recommendations at the 80%, not at 85, not at 100, not at, because it created an inequity between the various service lines, that some were getting higher reimbursements than others. And I know that we've discussed that even in the validity of a Medicare benchmark, whatever that was, it may or may not be an appropriate amount. I mean, in EMS, the Medicare benchmark, if you will, in no way covers cost. And even when I remember going back to the EMT recommendation of 80% of the benchmark, that's what that was based on. The previous work that we did when we established the committee in the first place.
I don't
I know
know.
that might not be helpful.
Oh, thank you, Tim. I don't know when the committee set the 80% of Medicare, but I know the 204 CMS new access to care statute, they has the target 80% of Medicare. If we can't meet that goal, you need additional access to care analysis.
Correct. And as you say that, Ling Ling, I think that was when access to care was a barrier, that may have been where some of the rates changed, but yeah.
Okay. Do we have a proposal here?
I mean, I'm going to propose we keep our current recommendation, and if we want to have the broader policy conversation, to have that at the end.
Others?
I agree.
Disagreements?
I know we said this is a policy conversation, but the fact that the stakeholders said that these rates have not been reviewed in 20 years is not something I'm comfortable with. We cannot have a flat policy for everything. And if surgery rates are reviewed and this is not reviewed, nothing has stayed the same over 20 years. And we should.
No, reviewed at 20 years at the federal level.
Correct.
Yeah. You're saying that if something hasn't been reviewed within 20 years of the federal level, I think Megan actually clarified that it has not been 20 years, that, pardon to the stakeholder, it's
It
only
has
been
not
6.
been 20 years. Sorry,
Okay.
sat on the like AMEA RVU update committee, which makes recommendations to CMS about Medicare codes for physician services. And this was reviewed in the time that I was on the committee. I can't remember what year it was, but it has been, within the last 6 years.
Okay, that's helpful.
There are some codes that go like, a decade or sometimes more without being reviewed if, they don't have big utilization changes or big changes into the technology that impact how they're used.
Okay, we've got Ian's recommendation in the chat.
I think this is like a deeper question beyond Mprrac. This is for Medicare benchmark services, where within this range do we believe they should sit? And so I like some sort of policy recommendation. I'm flexible on the details. I'm trying to put something into the chat, which I've put, which basically is we need to have a standard for what this is. Is 85% the right number or a different number? And I think that's a reasonable policy recommendation for us to make. Are
I
folks
agree.
comfortable?
I agree with you, Ian. Yeah, I think we need, 85 was a very arbitrary reduction. So there's some services that just does not make sense for. I also just want to reiterate what Ling Ling said, was that if the stakeholders have that private insurers information, sometimes that's moved the needle because that market reimburses at such a higher rate than Medicare. Then that allows us to have other data to make, for JBC to make decisions and HICPUF to make decisions. So, but I don't think we can, in this recommendation, say 100%. Our recommendation has to be the same. We're putting this separate recommendation in the policy piece. And again, to the stakeholders, if you have that private payer information, please do share it with HICPUF. We have a really difficult time getting it.
Are members comfortable with a policy recommendation like this for this service and any other service that is also benchmarked the same way, which I believe is the surgical services is the other one?
Yes.
Yeah, that seems like a fair approach to an unfair problem.
Like, I'm going to say, like, maybe not really. My issue is that surgical services are the set that we're reviewing right now this cycle. And then there are other physician services or other Medicare benchmark services that are not being reviewed this cycle. And so I feel like a policy recommendation like doesn't just apply to things that are being reviewed this cycle and like just needs to be applied to,
Are you supportive? Just so I hear you correctly, Megan, are you supportive of if we make it not a service specific recommendation, but like a general recommendation across all of Mprrac, all of HICPUF, regardless of what's being? Are you supportive of it that way?
Yes, I am supportive of that.
Okay, are members supportive of that if we make this not an anesthesia specific recommendation, but I don't know where this would go in the report, but it's basically like a cross-cutting recommendation to evaluate the ideal target range for Medicare benchmark services?
Yes.
Yeah.
Well, and so this is Tim. So this is all services that have a Medicare benchmark, not just these particular set that we're reviewing this year, because we got to be consistent.
Yes, that's correct. That's what I'm proposing. And if we want to resolve the conversation now, we can do that. I think that part of what's confusing is that we're discussing this while we're discussing anesthesia services, as opposed to having it as a separate conversation.
So does the conversation need to be broader, like towards the end of the year or the first of next year? Maybe we need to, the committee, I don't know if we will include me next year, but the standard approaches that we make regarding our recommendations needs to be refreshed.
Yeah, I mean, I think that if we are wanting to make a policy recommendation that's considered this budget cycle, then we need to make some statement this meeting. But I 100% agree that talking in November about, just evaluating the methodology that we've used and how we want to think about a methodology in future years is a great conversation for November.
I would agree. It's typical for what we've tried to do in November. Should we put that on the November agenda?
Yep, it's on there.
Okay. All right. So back to anesthesia. Recommendation here.
Again, as shown.
I'll second that.
Agreed.
Yeah, agreed.
I think we're agreed on what's shown for anesthesia. So I think, is anyone opposed to that for anesthesia? Okay, I think then for the policy recommendation that I put in the chat, I think there are three options. One, we can do it for anesthesia. Two, we can recommend it globally across all services, given there was just this 85% cut that happened earlier this year. Or third, we can do nothing and for a policy recommendation. And I can't understand. It's unclear to me if we're going down. People are recommending path one, path two, or path three. And so can members speak up for which of those three they are wanting?
Path 2.
Ian, would you say those three again? Please.
Okay, I'm gonna write it down just so that we are crystal clear and there's no confusion. So this is the recommendation. Again, there was for Medicare benchmark services, there was this cut to 85%. We would have a policy recommendation that HCPF evaluates the appropriateness of where within that 80 to 100% range, is it 85% or something else that should be kind of the default target. And so we can recommend that for anesthesia. We can recommend it for all services that are Medicare benchmarked, or we can not make the recommendation.
Langley?
I want to point out the resources for the research for all services. I feel it's more long-term goal. Maybe for anything that is short-term goal is better.
You're saying it's more practical. Number one is more practical because it's like very defined to one service versus number two is like
yes.
everything in the Medicaid program, basically.
Yeah. They have more than 20 services. And anesthesia now, they have the issue that anesthesia is the only service the provider say the CMS, the Medicare methodology is flawed. Other services, we never heard about that complaint.
Can members speak up if they have a preference for path one, path two, or path three, or no preference?
Anisha?
I like path 2, but just because of what Ling Ling said, for making it more realistic, let's start with anesthesia, see how doable that is, how many resources we have, start there, and if resources time allows, then extend it to more services, especially when stakeholders are involved and bring something to attention that should not be ignored.
I would agree with Manisha, given the information we got from Ling Ling, but I think Tim made a good point too, that this may be an overall refresh of our guideline baseline, kind of approach to things would probably be appropriate, but maybe just for anesthesia on this particular item.
I go with 2.
Yeah, I mean, I feel like most comfortable with 2, but then because of what Ling Ling said, I would go to 3 and have our conversation in November. So.
Yeah, thank you for that. But the problem with 3 is this impacts just anesthesia, or what we might be recommending from anesthesia on. Well, I guess 2 does the same thing, but I just want to make certain that we're being consistent in what we do, how we apply our recommendations and everything.
Yeah, I mean, I feel like I'm in position of bad guy today. Like, I definitely have heard how challenging things are for anesthesia services, and I feel like we heard how challenging things are for NEMT, and they're fighting for living wages, and so I think that we do need to think about the methodology and how we're going about things and making sure that we're doing things in a way that is fair and reasonable and has some degree of methodology, like has some point of comparison. So I 100% agree that if there are groups that have commercial rates that we can compare to or use some other data source, that will be helpful for making comparisons and making recommendations in the future. But in the absence of that, like, this is a set of services that is compared to one of our strongest benchmarks, and we're using a pretty typical convention. So yeah, I mean, I have a hard time with it. I do understand that, like, to some degree, this is a set of services where the providers don't have a lot of choice in deciding who they're working with. I mean, they can't, like, cherry pick and not accept patients on Medicaid. But I just sort of favor the finding a path towards consistency.
Guys, I'm gonna intervene here. We have been spinning our wheels for 30 minutes. We have a lot more to cover today that's not going to get this kind of attention. This is a topic we can do in November with more thought and preparation. I'm not seeing a resolution at this point.
I'm gonna agree with Megan. I think we have to have some consistency with our methodology, and I think that's where we have to go from here. I think 2, but 3 makes the most sense.
I don't like 3 because 3 happens after the report is written, so we're basically silent on it in the report, and I think that's important because for providers, the 85% cut happened in it's like April, or I forget, it was this year. So I almost like do number 1. So we have something on the record in this cycle around evaluating the appropriateness and addressing the stakeholder feedback, and then we can come back to 2 in the November meeting when we have more time.
Lingley?
We'll have a compromise. Maybe put in the report, you can say, because of the special situation for anesthesia, you can say research the anesthesia as a short-term goal, and for all other services with Medicare rates as a long-term goal. How do you feel?
I like that. I think that's very practical.
So Ling Ling or Ian, if we were playing Jeopardy, would you put that in the form of a question or a motion, the whole thing?
And also in the chat again, please.
I'll try and type it out. I think this is what you were trying to say, Ling Ling. Um, did I capture what you're saying correctly?
Yes, perfect.
Okay. Members, are you comfortable with this?
I mean, I feel like this is option one. Um, and I mean, I think if we want to say something, then I can like get over my feelings. I just feel like there needs to be more information, and if we're asking for more information in terms of why this 85% change or any other adjustments that have happened to anesthesia services seem to have had such a disproportionate impact, like I'm all for like getting more information about why it seems like there's been a larger impact on anesthesia services. I don't I don't know that I would put it as deciding, like having HICPUF give a recommendation in terms of what's appropriate within that target range. I think to some degree, like I see that as being our role. Like that's why we exist. They get the opportunity to make their recommendations. But understanding more about why does it seem like there is a disproportionate impact on anesthesia services, that's something that I can support.
Okay, so Brian, can you just so we can continue moving forward, my thought, do you have a suggestion? My thought would be maybe we have a couple different proposals and people can vote for one and we can kind of go from there. But any other, I just want to make sure we can keep moving. And
I
is
would
there other
I would
suggestions for breaking
suggest,
the impasse?
I mean, I would respectfully suggest that we do this in November, unless you feel like you have to act now. That we have so many other services to cover, and I don't feel like they're going to get this kind of treatment just because they're in that order. And trying to make sure we allocate our time, and we're really long.
Are you typing something in, Megan?
Yeah. As like for the policy recommendation portion or whatever you want to call it.
I'm good with this, and then we pick up the broader 80 to 100% thing in the November meeting.
Yeah, I think so. That would be a good recommendation.
So are we going with no change to the slide with this additional recommendation?
The one that Megan typed in, yes.
Yes, so no change, but we're adding this recommendation to our recommendation.
As a policy recommendation, and then we can pick up the broader discussion on this at the November meeting.
I can go for that.
All right. Any dissenters? All right. I think we are good.
Yeah. Thank you.
Thank you for the work on that.
Absolutely. I think we deserve a break, everybody, or well, yeah, we're over time. So I suggest we take 20 minutes for a quick break, or maybe less, and then get right back into it.
Maybe we do 15 minutes just to be efficient with time and come back at 12:20. Does that work?
Good for me.
Does that work for
Okay.
everyone?
Yep, sounds good.
Let's do that.
We'll
Thank
see you at 12:20, everybody. Thank you. Welcome back, everybody. Hope you had some peaceful moments.
I think, Brian, just in the interest of time, why don't we go ahead and get started?
Yeah. Yeah, I just saw Kate joined. I think we're all here. Michelle, you ready?
Ready. I just have my camera off for a few minutes while I finish eating my lunch. I'm sorry about that.
It's all good.
We're here though.
We'll go ahead and progress the slide. We go to ASC, ambulatory surgical centers. Here, as we saw in the summer, we were at 80.6% of our overall benchmark ratio. Our recommendations were to raise any codes below the 80% to 80% with a 3% increase for codes without. That would be a $700,000 fiscal impact overall. On the pragmatic side, we said raise any codes below 80 to 80 and reduce any codes above 85 to 85. Then 3% increase for codes. The rebalancing there would be 132,000 with the 3% increase. Now I'm being a little more material, 291,000 for a total of 423. Do you have any public comments?
We do not.
Members?
I felt comfortable with our recommendations, just because I made note of preference between our ideal and pragmatic. I think these and the other surgical codes are one where, if possible, ideal is great. And that's it.
I feel good with it as well.
Same.
Any objections from anyone on the committee?
Nope.
Great. I think that was a no as well.
Yep, that's what I heard.
I think we're good to keep going.
Perfect. Thanks, everybody. We go to dental. Remember, we have two here. We have the state dental plan and then DIDD, dental for people with intellectual developmental disabilities. Starting with the state dental plan, we were at 97% overall on our benchmarks. Our ideal was to go to 100 on the benchmarks using other states, leaving those above 100% the same, and a 3% increase for codes without the benchmark. That would get us to 107 overall. That would be a fiscal impact of 44 million to increase the below 100 to 100, and then 125 for the 3% increase. On the pragmatic side, we said no change for codes with the benchmark ratio and a 3% increase for those without. So that's 0 on the first line and 125,000 for the 3% without, getting you to 125. Any public comments?
Yes, we have 3 people, starting with Lauren Harvey.
Hi, Lauren. You there?
Yes, I'm here. Can you hear me?
Yeah, you got 2 minutes, please.
Thank you so much. My name is Lauren Harvey. I am the Director of Government Relations for the Colorado Dental Association. Thank you so much to Mprrac members and HICPA for all your work on this. I know it's a lot, and we really appreciate all the work that's put into this. A few quick notes as far as prioritizing services today. We want to make note that we've appreciated this committee's commitment to understanding the impact of oral health care on a person's overall health. And we know that dental care is not only an important healthcare prevention tool, but it also saves money in the healthcare system. So to some of the conversations you had earlier, When we do not, invest in dental access to dental care, it does increase the use of emergency room services and other emergency services. There are studies that show that individuals who have appropriate dental treatment have significantly lower rates of hospital admissions, 67% lower. So I just wanted to make note of that. And also just a reminder as far as prioritizing for when the state, does have funding eventually, hopefully for services. Dental has not had a full rate review since 2018. It got caught up in this switch from 5 to 3 year review. So in 2023, dental only had a 28 code review, which was very important. But just a reminder that the vast majority of dental codes have not been reviewed in 8 or more years. So we do want to ensure that those continue to be looked at when there is funding available. And then a few other folks who will testify will note this, but as far as recommendations for if and when there is funding and priorities, we would prioritize dental codes related to preventative services like oral evaluations, prophylaxis, sealants, as well as emergency services codes, anesthesia services codes, and then endodontic and periodontal codes. Some of those specialties are very important, especially for Medicaid, when we don't often have enough providers to provide care. But we know that having rates adequate and sustainable does increase access to care with more providers. And then lastly, I just want to encourage the committee to go ahead and have that conversation that you've already discussed at your November meeting regarding commercial claims data. We know that you've chosen to benchmark to other states for this year. And
wrap up, Lauren.
okay, thank you. We just want to note that Colorado does have the All Payers Claims database with very comprehensive, robust information. As you already know, CDA worked with Civic on having that public dental claims data. And we just want to note that because it's obviously not benchmarked to Medicare, we know that the way that Medicare determines their fees for medical services includes a number of provisions that is very similar to how a dentist might set their fees in their office. And so that's why we would
Lauren, we have
suggest
to wrap
having
up.
that conversation. Thank you.
Yeah, thank you.
Next, we have Jeff Lodel.
Sorry, that was garbled. Who?
Oops, I'm sorry. Can you hear me now?
Yeah,
Jeff Lodel.
Jeff. Yes. Go ahead, Jeff.
Hi, I'm Jeff Lovell. Yeah, I'm president of the Colorado Dental Association. Thank you and the Mprrac members for reviewing these rates for us. It's been a long time since 2018, I believe, since we actually had a full review. We only had a partial review in 2023. Thank you for all your work on your benchmarking. We still do feel like having civic data is helpful for us because most of these are by private practice practitioners. We'd really like you guys to have preserve our endodontic codes, our preventive codes that are a little above the 100% benchmark right now. Those are really important for prevention for this group. We're able to get about 8 or 10 more endodontists actually to take Medicaid for our endodontic codes. So we'd really like to have you guys help preserve those codes as well as our periodontal codes for periodontal maintenance, scaling, and root planing appointments. A lot of your other codes, I've had a chance to look at your Excel spreadsheet, and a lot of them look to be pretty reasonable, except for we'd like to really help maintain those to have better access to care for our population. When they have no specialist that we can refer to, it makes it very challenging for them. They end up just having to have their teeth extracted by the oral surgeon or somebody else with sedation, which makes everything more expensive as well. Their periodontal codes would really help keep their gum disease healthy and keep people out of the ER and much more expensive care for people, as well as there's some studies show at least 28% more chance of heart attacks for people with gum disease as well. So trying to do prevention for those would be really helpful for the overall cost for Medicaid. Thank you.
Thank you, Jeff.
Thank you. Lastly, we have Kevin Patterson.
Welcome, Kevin.
Great. Thanks. Can you guys hear me?
Yep. 2 minutes, please.
Okay. One, I want to thank you for allowing me to speak today, and also for all the hard work. I've been listening to the meeting off and on today, and these are all tough decisions to be making. I'm an oral surgeon in Denver and part-time faculty at the School of Dental Medicine at Anschutz. I'm the oral surgeon who sees the patients that aren't able to see providers to have fairly routine dental care taken care of. These are the individuals that, because the number of providers is low, especially in the field of endodontics, which is root canals to save teeth. These people let things go until they present to the ER. And then my job, I come in and I take them to the OR. That usually involves a 1 or 2 night hospital stay. I'm sure you guys can all imagine what that costs for these individuals. It's upwards of 20,000 patient visits a year in Colorado to emergency rooms for dental problems that should be able to be managed in the dental office. That equates to conservatively over about $50 million in care costs that hospitals have to forfeit the funds. We essentially do it for nothing because these patients don't have other insurance or other means of pay. So we just take care of the patients. So what I would like to see is, work on, which we've worked really hard on with the CDA, the preventive codes, the codes that can allow people to keep their teeth, to keep them healthy and keep them from seeing me at 2 o'clock in the morning in the ER. One other area would be anesthesia services in the dental office. One of the biggest limitations on access to care is getting the dental anesthesiologist to be able to take care of patients that would normally have to be seen in the hospital. It is significantly less expensive on the system for these individuals to be cared for in a dental office versus doing routine stuff in the OR. So I appreciate your time today. I appreciate all your hard work and look forward to working with you guys in the future. Thank you.
Thank you, Kevin.
Thanks, Kevin. No more public comments.
Members. Manisha.
I want to ask if this is within the scope of MRAC. The state implemented a $3,000 annual max on dental services effective 1st of July. And if this is something that we could write in terms of policy, being a dentist for over 20 years now, I know this is not going to save money. What I can fix with $100 filling this year, the patient or Medicaid will have to pay $1,800 next year because by now they would need a root canal. The state had this adult cap when it first started in 2014 at $1,000, and then they increased it to $1,500. Then the cap was lifted, and now again, starting 1st of July, every adult Colorado Medicaid holder in Colorado has a max of $3,000, which I don't see how the state is saving money on that, and I feel is going to come bite us bigger, not in far future, immediately.
Yeah, thanks, Manisha. The committee is free to recommend changes to the cap if you so desire.
We could do that, Manisha. That is, we could at least make a policy recommendation around it. Why is the cap in place, or what is it supposed to do? I assume it's just meant to like cut costs, but is it anything more than that?
No, it was to cut costs, and majority of procedures that pay over $200, $300 need a pre-authorization from DentaQuest Medicaid. Every procedure, including if somebody has toothache 3 times a year, they cannot see a dentist more than twice because there's a frequency limitation. So to say yes, it would cut cost, immediately patients would have to wait longer in pain or end up in ER, which again increases cost but not saves. This I felt was very important to lift this annual caps. There is very, very, very little room for negligence here, for wastage here, for fraud here, because of all the frequency limitations and the pre-authorization procedures that are in place.
Nicole?
Yep, but you answered my question. Thanks, Manisha. I wanted to know what the impact was. So that's great. Thank you.
Thank you.
So the proposal is to remove the cap. Go ahead, Ian.
Maybe Manisha, do you want to type in like language into the chat that you would be interested in? And while you do that, any other comments from members here?
This is an area where I again felt comfortable with our recommendations, and just because of the fiscal impact leading toward the pragmatic option. And then I think just hearing the stakeholder comments might recommend to make sure that they're sending to the department which codes they consider preventive, like primary prevention versus secondary prevention, so that if we're sort of trying to prioritize the codes, or the department's trying to prioritize the codes, we really know which ones you, again, consider in each of those categories: primary prevention, preventing anything bad from happening before it's happened, and secondary prevention, preventing anything from worsening.
We have Ivy on the line.
Good afternoon. Yes, I am here. Could you repeat the question or statement? I apologize.
It was just a statement really toward the stakeholders. I think, we've been trying to prioritize preventive codes, and I think, HICPUF has done their part in trying to identify which codes those are, but I think that it is helpful for stakeholders to take the opportunity to share their opinions about which are key preventive codes from their perspective. So that was the only suggestion.
Lingley?
Ivy, could you please explain why the GPC put the cap to the dental at adult services?
Yes, I'll be happy to. Once again, my name is Ivy Baville. I'm the Medicaid dental specialist here at the department. The primary reason for the $3,000 max was due to budgetary reasons, right? But in that decision-making process, we did do a lot of looking at data in the prior fiscal years to kind of inform us where that cap should be based on utilization patterns. So the $3,000 was not something that was just picked out of the air, so to speak. But we did look at data and utilization patterns for our adult population over the past few state fiscal years when there wasn't that cap in place. And that really did inform a lot of our recommendations in terms of the cap. And as far as preventative services are concerned, we do acknowledge and realize the importance of preventative care. And I do believe a number of preventative services like adult and child prophylaxis, the sealants, things of that nature did see that increase when we made adjustments to those 28 codes back in 2024. We do know that those were reduced, again, due to fiscal and budget impacts. So we did, in collaboration with the CDA, recognize and honor those that work to ensure that some of those higher utilization codes did receive those rate increases.
Thanks, Ivy.
Can I just a follow-up question to Ivy? Sorry, this is Kate. My camera's off, but Ivy, when you guys chose a cap as a methodology, and again, just let me know if this is outside this conversation, why did you choose a cap as a method? Because this happened in my industry where Medicaid looks to private payers for some of their cost saving ideas. So one of those in behavioral health was capping behavioral health visits to 20 visits a year. That's just something that comes from the private insurance standards. It's not based on any type of actual clinical studies or any type of idea of like what is really important for patients. Or I think what Manish is trying to say is that a cap is not a medically smart intervention for cost savings. Just like 20 sessions per year is not a medically smart intervention for cost savings. So could you, again, you don't have to answer that if you don't know, but you said you tried to pick a good number for the cap, but picking a cap in the first place usually is because you're following private insurance's standards. Like I've had a cap on my insurance before. Doesn't mean it's good medical sense.
Christopher?
I just had a question for either Ivy or Manisha, whoever might know, as to how this cap for the adult state dental plan applies, or how it compares to pediatric being 0 through 20 and DIDD, if there's similar restrictions on those programs.
Pediatric age 20 and under does not have an annual cap. It's adults 21 and over, and DIDD, I do not know. Ivy?
Yes, thank you for the question. Great question. For the IDD population, They do have access to the adult state plan, just like all of the other Medicaid adults, and so they are subject to that $3,000 max. But then they do have additional dental coverage under their specific waiver. So either the developmental disability waiver or the supportive living services waiver.
Thanks, Ivy.
Okay, thank you. That's what I understood. I just want to make sure that was correct.
Yep.
So we have a proposal to remove the cap. Anything else as a proposal? Ivy?
I apologize. I just wanted to recognize Kate's question. I know we kind of got off that question, so I wanted to round back. I do not have the historical information as to why a cap was selected. But to your point, Kate, you know, with commercial insurance, it's very common to have caps for dental based on benefit years. Commercial insurance anywhere from $1,000, $750 to $1,500 is very typical. But for the Medicaid, I do not have that information historically.
Thanks,
Thank you.
Ivy. Lingley?
For Ivy, you said you did the analysis, like past year's utilization pattern. Do you have a number at hand to let us understand what is the percentage of Medicare utilizer for adult services? It's under 3,000. It's like 80% or 9% or more than 90%.
Yeah, so thank you, Ling. So when we looked at the data, what the data revealed is that with let me take a step back. When we looked at the data, we found that the 90th percentile of our member adults, the average utilization over a state fiscal year averaged about $3,400. I think it was $3,417 to be exact. So when we made that recommendation, we put that forth to leadership. I don't have the information around how it was landed on $3,000. I don't know if it was what that looked like, but that was the data that was used to provide leadership so that they can make that decision on the cap.
Thanks, Ivy. Tanisha?
I was on the JBC call when this proposal was made in 2025. They were trying to implement an annual max even in that year. And the conversation that was to answer Kate's question, why was this being even brought up, was comparing it to private insurances that dental usually does have a max. And going off of the percentage of patients that cross this annual limit, if it's a small percentage of patients anyways that cross this limit, budgetary wise, this should not make a big difference. But for those patients that are crossing this annual limit of $3,000 and are delaying care, that impact coming back, like I said, what's $100 fix this year would be an $1,800 fix next year, is going to be worse. So we are not saving too much with this just because very small percentage of patients cross this limit, but we are adding more to the cost because those that do cross this limit will end up having to pay more for.
Yeah.
I think that's a compelling point, Manisha, because unlike commercial insurance, Medicaid will pay for the medical costs associated with this. So if you have a tooth infection and you have to get whatever thing you need and a procedure, they'll just go to the emergency room and then they'll get it in the emergency room. And so Colorado Medicaid pays the same. I think it's not about it's like keeping the patient healthy so that they don't need more expensive services either in year or down the line. I think that makes a lot of sense.
Lingley?
Ivy, do you have the data at hand? What is the fiscal impact for this 3,000 dental cap for adult members? I know the population size impacted may be small. I just curious, what is the fiscal impact?
I don't have that information right in front of me, Ling Ling. I apologize.
No worry. Thank you.
Tim?
Thank you, sir. So once again, I'm going back to, so the ceiling is now $3,000. The data shows that the average use was 35. Is that right? The 90th percentile? Is that correct?
It was 3,400. And I do want to also make sure, and I think it's really important to note that within this $3,000 max, there are some exclusions, right? So emergency services are excluded and also dentures are excluded. And we understand that these two categories can consume quite a bit of a member's maximum. So it was very important to the department to preserve those services without any harm to the member and the max. So we also need to, I think that's an important thing to keep into context as well when we're talking about the member maximum and some of these higher cost services.
Thanks, Ivy.
So did you say they're now included or they're still excluded?
They are excluded. Emergency services and dentures are excluded. They do not count towards the maximum.
So emergency services wise, if it went into the ER, they get charged the facility fees and everything, but they would be denied any dental services that they perform in the ED, if they perform dental services in the ED.
Yeah, correct. So the ED is a little bit different. Our oral surgeons and Dr. Patterson, I know that you spoke to this a little bit. They are duly credentialed, so they can submit either dental codes to DentaQuest for reimbursement or CPT codes directly to the department for reimbursement based on the type of service, where the service is rendered, and in what situations. So depending, and that's at the discretion of the provider. So if CPT codes are submitted to directly to the department, that would come out of the medical side where the dental maximum is not even affected. So just there's that situation as well to keep in mind.
I'm sorry.
Thanks,
Yeah, I think we got a little off track. I think we're just trying to decide if we support Manisha as a committee to recommend that the cap be removed. And then I'm just asking the committee, like, how do we want to make that decision? Do we just want to vote and be like, yep, I don't want a cap? Or do we need additional conversation to determine that? Sorry.
Well, I would say we need additional conversation to be consistent with some of our other recommendations. Because I could support, instead of removing the cap, to maybe raising the cap at least 500 above what the 90 percentile of 3,400 is for now.
Other members' input?
Yeah, I don't understand, Tim. I'm sorry. Like, I think the proposal on the table is keep the cap or don't keep the cap. If you keep it, then that's a different conversation about what to raise it to. And it does sound like HICPUF has already done all those metrics. Like they picked 3,000 using a lot of data. So I don't want to duplicate that work. So I think it would be more about whether or not as providers, we feel like caps are appropriate way to save costs. Like that's my purview as a provider, is that caps on care, especially primary care, don't save money. That's true with mental health as well. And Ian's point is exactly right. You know, if you're a private person and you have to go to the ER, you pay for that. But if you're a Medicaid person, you maxed out, you use emergency services, we pay for that. So that's the same with mental health services. Chronically mentally ill people need ongoing mental health services. It makes no financial sense to limit them to 20 sessions a year. So these are both private insurance standards that really don't apply in Medicaid. So my recommendation is just to say, as a policy recommendation, remove the cap for medical reasons. We don't see it as a medical cost saver, and it doesn't have a medical justification. That would be my recommendation. Sorry, I'm not here to type that in the chat.
I'm like happy to take a vote on that, but I'll just say I also sort of feel like I need additional information. I hear that the department put a lot of consideration into, you know, having a cap versus not, what is included in that cap and what is not. And I heard that emergent dental services are excluded. So even if somebody went to the emergency room, whether they were billed as medical CPT codes or they were billed as dental codes, that it's like carved out, and that denture services are carved out. So I just feel like I don't have enough like
Well,
information
yes.
to
Yeah, let me clarify then. Yeah, let me clarify a little bit then. So it's my understanding from what Ivy just said, and Ivy, correct me, was that they actually did not put a lot of consideration in having a cap. What they put a lot of consideration in was what the cap was. So that's the first thing I wanted to disambiguate. They just borrowed cap as an idea from insurance companies. I think maybe, but Ivy might just not know if there was historical discussion of that included providers. But
that is what I heard as well. So yeah.
Okay. And then Manisha, I couldn't quite understand your math. I hear you want to get rid of the cap, but it sounded like more that was because people were delaying primary care services because of the cap. Maybe you do need to speak to that dynamic to us.
Yes, please. And that's exactly what's happening. So, emergency definition according to Medicaid, if a patient is in pain or has infection, think of this cavity that's very close to the nerve. It needs a filling, and Medicaid pays $108 for that filling. And the patient is still not in pain. And by the time he waited, and came next year, July, this time a filling is not going to solve the problem. Now that tooth would need a root canal that Medicaid pays $900, would need a buildup that pays $135, and would need a crown that pays $700. So, what was non emergent but still primary care that was needed at that time could have been resolved at $108, now would go to $1,800.
And
And
you're just so I understand, you're saying that a person is putting off primary care just because they have a cap and they are scared. Since they have a cap, they're like, oh, I got to keep. And so this is like an economics model. You're saying the individual member has an economic incentive to put it off because they want to save their $3,000 for a rainy day. And so you want to incentivize them to do primary care by not having a cap they have to worry about. Is that what you're saying?
this part, and also not every individual knows that this tooth can wait or whether this cannot wait until next year. If I said,
Right. So the patient, the member is making a decision about whether they can put off care based on finances, not on a medical recommendation. That's what caps do. That's actually why insurance companies have them, is to deter individuals from using their services. That's what I'm saying. It doesn't have a medical reason. It has a financial cost saving reason that won't save us money, saves the insurance companies money. Thanks, Manisha.
yes, and may I please also add about emergency care? Again, going off of definition, taking somebody out of pain or taking care of infection defines emergency care. If it's a child coming in pain, needs a root canal, and getting them out of pain, I can start a root canal, put a temporary medication in there, but that temporary medication is not going to last for the next 11 months or 6 months. It's supposed to last there for 2 weeks, and then the child will come back again. I would either need to extract that tooth, child exempt, 22-year-old, 26-year-old, either I'll extract that tooth and then pay to replace that tooth because dentures are exempt. So even in that argument, we are not saving any money. And as a healthcare provider, a new patient comes, I triage based on what I am taught as a dentist, that this is phase 1 care, phase 2 care, phase 3 care. But all of a sudden, I start triaging, okay, I have $3,000. I am in this area, but I'll work on this one tooth because that other tooth hopefully will wait for next 6 months or next year, and it may or may not wait.
Yeah. So just so people understand, this is the same reason when you talk to a legislature who doesn't understand these things because they're not a provider and you say, yeah, we're going to put a cap on this. It says, great, that feels like cost savings. Same for mental health care. 20 sessions a year, that seems like cost savings, but they don't understand that we have different financial burdens than insurance companies. So just want to explain that to people. It's very rarely a good idea to borrow private insurance's business practices.
Okay. Do we have a proposal then that we can put on the table? I think we have one with Manisha. Are there others? Okay. So the language in the chat, right? Going back a little bit. 1230, 1236. We had proposal to remove annual dental benefit max for Health First Colorado adult members, which is currently 3,000.
With the caveat, because it deters people from getting primary care, and that is not in Medicaid's best interest.
I like that language, can you or Manisha like add that in? I think it helps provide color to what we're trying to say.
Kate, would you please write the way you
Yeah, I'm happy to. Yeah, sorry, I just stepped away from my desk. Okay, one second, I'll do it right now.
Thank you.
Okay, we have that in the chat.
Yep, sorry. I'm happy to edit my language. So it's always feisty when I end up talking about private insurance.
Do we have a recommendation for the policy change, removing the cap? Feedback on this? Support or oppose?
I guess I'll say I'm opposed because I just feel like it's something that needs more research. But yeah.
This Tim, I'm opposed as well.
I'm opposed to removing the cap on the dental as well. Although I will acknowledge Kate's point on capping mental health services does seem counterintuitive. I'm not saying this $3,000 is the correct cap, but I think like the other folks said, we need to talk more about the dollars and how we got there, but I'm not sure we're going to get that today.
I'm in favor.
In favor, and may I also add that removing the cap is not the same as removing the frequency, so those still apply.
I think we're at 4 and 3 against. Is that my count?
I think I'm in support, Nicole's in support, Manisha's in support, and Kate's in support. Megan, Christopher, and Tim are not. And that I think is like very close. And so I lean towards we include it, but then Brian and team also just highlight in the report that this was that there were 3 dissenters.
Yeah, I think that would be warranted.
Does that work?
Yep, I think that's the correct process.
Okay. All right, let's keep going.
Thanks, everybody. All right. Next up, the DIDD. Here we were at 146, almost 147 overall on the benchmarks. We talked about the ideal of bringing codes below 150 up to 150, codes above 200 down to 200, and a 3% increase for codes without a benchmark. That would get you to 161 overall. The pragmatic was bring codes below 150 to 150, bring codes above 200 down to 150, and a 3% increase for those without. The total impact on the ideal would be about 700,000, and the pragmatic about 426,000. Any public comments?
Yes, Lauren Harvey.
Hi, Lauren.
Hi, Hi. Sorry, it just takes a minute to unmute. Lauren Harvey again, Director of Government Relations with the Colorado Dental Association. Again, thank you so much. Just a couple quick comments for the DIDD. First of all, appreciate all of the work that's gone into this last year and this year and the benchmarking above the traditional Medicaid dental rates. One note is for the recommendations around bringing rates down in this category. The concerns would be one, that if those 200% rates are benchmarked to what I mentioned, a lot of the dental benchmarks actually haven't been reviewed or updated in 8 or more years. And so while 200% sounds like a lot, if it's benchmarked to a Medicaid dental rate that hasn't been reviewed or updated in nearly a decade, it actually might not be as egregious as it sounds. And there could be some concern about reducing services to this particular population if we are reducing rates. And then I just wanted to note again, as far as prioritization goes, again, prevention is always, those prevention codes are always going to be a priority, including for this DIDD dental. And we would also emphasize the anesthesia related codes. Again, I think you all already know this, but this group of patients can sometimes need more anesthesia type services to get kind of traditional dental services, just to ensure that they can have care provided safely to them. So just wanted to note that, and I appreciate your time again. Thank you.
Thank you, Lauren.
Thank you. And we have Jeff Lodel next again. Jeff Lodel next.
Jeff, you there? I don't see him on
I
the
see
list.
him. It looks like
Oh,
his
there he is.
screen was getting a little fuzzy.
Jeff, are you there? May have stepped away. Jeff going once, twice. Oh, well, that's unfortunate, Jeff. If you want to keep trying, or certainly send in a drop the text in the chat if you like. Members, would you like to start discussion while he's working on his audio?
Yeah, let's start while he's waiting. Any comments here from members?
I mean, just to address the comment that came up this time and last time, like this year was the full review of dental codes. So while it had been a while since there was a full review and we did the partial review, this was the regular time for that full review to happen. And then this was a category I was surprised to see the 2 recommendations, and perhaps I'm misremembering the conversation from last time because my understanding
Can you go back to the slide?
Was more that like the DIDD services, being benchmarked to the standard dental services should just fall at a consistent percentage, that 150% above those non-DIDD, like their equivalent service. But yeah, I think that's where I stand. So I'd leaned a little bit more towards our pragmatic recommendation in this case.
Recording in progress.
Jeff, I'm getting feedback on your mic. Other comments, members?
I feel pretty comfortable with where this is. If you do look at the overall benchmark ratio on this slide, we are proposing in either scenario for the overall benchmark to go up from 146% to either 161 or 155%. I think we had discussed around 150% being appropriate here. And so I feel pretty good with where this is at. I agree, Megan, with what you're saying. I would lean more pragmatic than ideal. But I think I feel pretty comfortable with where this is at.
Thanks, Ian.
I'm good with this also.
Tim?
Just confirming on the benchmark, that was a Medicaid benchmark. There was no Medicare benchmark.
It is Colorado Medicaid itself. It is benchmarking against Colorado Medicaid.
Medicaid does cover dental services, and that's why we have Medicaid or civic as the stakeholders are requesting.
All right, are there any, oh, there's Jeff.
Jeff, are you there? See, you're on mute. Not your day, Jeff.
All right, do any members feel differently?
Jeff, I'm sure you're trying to unmute right now, but it's not working. Does anybody remember what it is? Is it star 6 to mute and unmute? Something like that.
I think it is *6 if you're on a phone.
I'm not sure what he's on.
I think just in the interest of time,
We got to move on.
We should.
Okay, thanks, Jeff. All right, behavioral health services, fee for service only. We start with mental health services. These are the top 10 codes. There was a correction here. There was a mileage-based error. We were at 78 point, thanks, that's okay. 78.2% overall on these codes. Our ideal would be to raise codes below 80 to 80, including 90785 and the 45-minute therapy code, raise specified therapy and evaluation and management codes to 100% of the benchmark plus a 3% increase for codes without. That would get you about a 5.5 million impact on the fiscal side. The pragmatic voice says bring codes below 80 just to 80 and leave others unchanged, a 3% increase for codes without. That would be a 1.3 million overall versus the 5.5 on the ideal. Any public comments?
We do not.
Members?
None. Just a reminder to members that this is not the capitated mental health services that goes through the raise. This is just the ones that go directly to HICPUF, which is a very small utilization.
Yeah. Thanks, Kate, as always.
This was an area where I felt comfortable with our recommendation, but again, leaned toward the pragmatic set.
Ms. Tim, I do as well. Lean towards the pragmatic.
This is Nicole. I agree.
Good to me.
Good to me as well. Any dissenters?
I didn't hear any. Yeah.
We feel good. Let's keep going.
Next up, substance use disorder, fee for service only. We were at 103.7 against our benchmark. Recommendations only to bring codes those below 100 to 100, no other changes, a 3% increase. This would be a very minor fiscal impact of $6,000. Public comments?
No public comments.
Members?
Support.
Agree.
Good
Support.
I have heard only support.
I support as well. Are there any dissenters?
Very well.
All right, I think we can keep going.
Integrated care services, fee for service only again. We had a range here of 78 to 95% of the benchmarks. Recommendations were to bring those below 80 to 80 and no changes otherwise, and a 3% increase for codes without. This had a whopping $54 fiscal impact. Public comments?
No public comments.
Support.
Members?
I'm in support.
Me too.
Yep.
Or
Okay. I think that's
Yes.
unanimous. Oh,
It
sorry,
was
Kate.
unanimous.
And yeah, we could keep going.
Perfect. Special Connections Service is fee for service only. Again, we had a range here of 53 to 104. The recommendation was to bring up to 100 those that were below, and no other changes. A 3% increase for codes without the benchmark. The fiscal impact analysis here was unavailable due to rate only comparison. There was just no utilization data in 24-25 or 25-26. So no fee for service claims for special connections were received. H2036 HD does have utilization, though capitated programming via the raise. Recommendations still apply, but we see zero fiscal impact. Public comments? Oh, go ahead, Tim.
I'll wait.
Sure.
No public comments.
Go ahead, Tim.
So once again, this is a Medicaid benchmark. Kate.
Can we go back to this recommendation? Thanks. I'm not sure.
It has no Medicare rates. It's all other states.
Thanks, Ling Ling.
Thank you. I can support.
I support.
I support. Any dissenters? All right, can keep going.
All right, we move to our surgeries. We start with cardiovascular.
Brian, briefly before we go, are there any public comments across all of surgery? Just there's going to be a lot of similarity here. And
There's one, I believe, or there was one at one point.
Yeah, there is one under the eye and auditory section, but none for other categories.
Okay, sounds good. Thank you. Do we want to start there and then go do the rest? I think that might be helpful.
Sure.
I would love to do that.
Close your eyes when we get to the slides. Thank you. All right, overall on eye and auditory, we were at 91.5. Our ideal recommendation is to bring codes under 80 to 80, those above 100 down to 100, and then the 3% increase for those without. That's a $17.9 thousand impact. The pragmatic was to bring codes under 80 to 80, bring codes above 85 down to 85, and increase the rates for codes without benchmarks. That codes without benchmarks would actually have a net positive fiscal impact. The 10,000 from the codes without would net you at under 219 in savings. These are additional analysis here, codes with utilization using a weighted average Medicare rate at overall benchmark of 91.5. You can see the number of codes and the percent of total codes and the percent of total utilization. For a non-facility setting, the overall benchmark is 77%. That's 59% of all utilization and 22% of all repriced amounts. You can see the breakout there just for the non-facility in the middle table. And then on the facility setting, the bottom table, we have an overall benchmark of 96%, 41% of all utilization, and 78% of the amounts. repriced.
Could you give a brief voiceover, Ling Ling, or whoever ran the analysis? I know we talked a lot about this last meeting, and just remind members around how we calculated each of these three so that we fully understand it.
I think
I can chime in.
okay, go ahead. Go ahead,
Okay,
Wei.
sure.
Okay.
I'm the analyst who did this. So historically, we've been using only the weighted average Medicare rate for benchmark because Medicaid does not have a separate rate for facility versus non-facility, but Medicare does have a facility rate and non-facility rate. So to compare with Medicare rate, we historically use the weighted average, meaning like for every single code, what's the percentage of facility and what's the percentage of the non-facility. We use that to get a rate for the Medicare to compare with the Medicaid. That's what is the weighted average. And last meeting, in the July meeting, we talked about want to separating them. So I added additional analysis for the non-facility setting. Says for those utilization, we compare our rate against the non-facility rate. And for the facility setting, we use the utilization under facility to compare with the rates, the facility rate in Medicare. Does that make sense? Mm-hmm.
It does. Thank you.
Sure.
Any follow-up questions? Okay.
We had the one
Public comment. Yeah, thanks.
Yep, from Cecilia Comerford.
Cecilia?
Jumping ahead. Yeah.
Yes,
Hello,
please.
my
2
name
minutes.
is. All right, sounds good. Hello, thank you for the opportunity to speak today. My name is Cecilia Comerford Ames, and I am the Executive Director for the Colorado Society of Eye Physicians and Surgeons. And I am actually going to read a brief statement today on behalf of our board president, Dr. Monica Ertel. We are here today to ask the committee to avoid any recommendations that would overall reduce Medicaid payment for eye surgery services. Our membership is committed to caring for Colorado Medicaid patients and providing access to vision-preserving and sight-restoring care. However, a recent survey of ophthalmologists in Colorado found that a vast majority of respondents believe the current Medicaid reimbursement rates are already below the cost of providing care. The survey also found that if the reimbursement rates were reduced further, more than 90% of the respondents who took Medicaid indicated they would be forced to either limit the number of Medicaid patients they see or stop accepting new Medicaid patients in order to keep their practices open. These findings underscore an important reality that we all know. Reimbursement levels have a direct impact on patient access. When payments do not keep the pace with the cost of providing care, practices face increasing challenges in sustaining services for Medicaid beneficiaries. Further reductions would only make these challenges more difficult and could reduce access to needed care for some of Colorado's most vulnerable patients. Vision is essential to independence, safety, and quality of life. We encourage the committee to not lower recommended rates as it will place a higher risk on Medicaid patients to preserve their sight and remain active in their communities. Thank you for your time and consideration.
Thank you, Cecilia.
Thank you. That's all the public comments for all of the surgery categories.
Thanks, Michelle. Members?
Would you go back to the recommendation slide again, please?
Any comments here from members?
I think this is another interesting point. If Medicaid is giving the same rate in the facility and non-facility setting, and if eye surgery is more likely to happen in the outpatient non-facility setting, then that certainly could be something that impacts reimbursement to that specialty more so than another surgical specialty where the overwhelming majority of their procedures are done in a hospital facility setting, and so therefore they're losing out what's different in Medicare is in outside of this facility setting, there's a sort of practice expense payment and a practice liability insurance payment, and that's the reason that it's different. So yeah, I mean, I think that could just be something to look at. More than 50%, it looks like, of these services are provided in the outpatient setting. And just trying to scroll back again through those other surgery services, it looks like 90+% of some other in other categories are performed in the facility setting.
Thank you.
So are you recommending anything different, Megan? Like your basic, yeah.
I don't think I have a different recommendation right now. I think for all the surgical services, I mean, I do sort of feel like the leaning towards the ideal recommendation, and I don't know. I mean, it just feels like something that probably needs to be looked into in some way to understand what the impact of having a single rate is, especially on folks who the majority of their practice is in the non-facility setting, and they're trying to cover the expenses of their practice.
Lingley?
I want to clarify with Wei. Wei, for the current fiscal impact analysis, is based on the proxy rates, right?
The fiscal impact is based on the weighted average.
Okay.
So you're saying basically keep the recommendation the same, but we would lean more in this particular one towards the ideal side of the spectrum because this service in particular is weighted more in the outpatient setting, which would put more providers at risk of a more substantial cut than what's shown in the data. Is that what you're saying?
Yeah, I mean, and I think just for all the surgical services, I would have said the same thing, but I think hearing this and looking closer at the data, I definitely would put like the eye surgeries more so toward that. And then I don't feel like I need to make a policy recommendation right now, but it is something that just, is an area of interest. And if it is meaningful to the specialty societies, then I, might encourage them to have that discussion with the department in the future about having a single rate versus having different facility versus non-facility rates.
Any other comments for members?
Lingley?
I have one thing to share. The department is working on to have a separate facility and non-facility rates for surgery. We work towards that direction.
Do you have a sense of timing on that?
Yeah, it need some time, not immediately.
Okay. Okay.
So back to the recommendations. Are we comfortable?
I think we're saying if there's no other comments, we're comfortable with the recommendation, but we want to more emphasize the ideal side of the spectrum, at least here and potentially more broadly in surgery. Does anyone disagree with that or any objections to that?
The only thing I would add is we would highly recommend the ideal side as opposed to the pragmatic side because I'd hate to see providers take that cut.
Yes, makes sense.
Thanks, Tim.
I'm so sorry. I think I missed some of that. Can you say that one more time, Tim?
I think that we should lean on heavily on the ideal side and not the pragmatic side.
We go back one slide. There it is. Thanks. Okay.
Okay, I
Any-
think any objections to keeping this recommendation the same?
If we are all leaning so strongly about the ideal side, should we not even remove the pragmatic completely and just propose one as the recommendation from the committee?
I think that's a good idea because when you look at the fiscal impact, it may sway some opinions on the JBC.
So new proposal, remove the pragmatic.
I still overall favor consistency and like, but being specific, I think we talked about at the end of the session, going through and talking about which areas we feel like are particularly important. And I think that, you know, a specific look at this and, you know, there were a couple other areas that this came up is probably where I would favor.
I hear 2 in favor of removing pragmatic and 1 not.
Any other input for members on this?
I feel this is not even something that me or Nicole so strongly feel about. We absolutely have to remove. I was just echoing the idea that if we all feel strongly, then we may even consider taking it out. But if it's okay for the name of consistency, it's okay to leave it in.
Mm.
I lean towards leaving it in at this point.
Zwingli?
I want to add a context. For the April 1st, the 85% of Medicare reduction, the whole surgery category has big impact. And many of your recommendation, pragmatic recommendation for each surgery subcategory are negative numbers.
Thanks, Zwingli. Okay, so I'm hearing leave the recommendation as is at this point.
I think we stay there. Let's keep going through the rest, and we'll probably want to be consistent across. So let's continue the discussion, and then if we feel differently as we make it through the other services, we can adjust as needed. Does that sound good to members?
Yes.
Okay.
All right, let's go back to the top of the surgery section then. And cardiovascular. So again, 86% at the over the last fiscal year against our benchmarks. You're ideally saying bring codes under to 80, 280, over 100 to 100, increase by 3%. That would actually be a net savings of 129,000. And then bring codes under 80 to 80, bring codes above 85, down to 85, and the 3% on the pragmatic side, that would be a savings of over 400,000. And then here's your weighted average breakout, facility, non-facility.
So I would again say for this category, for this and for surgeries across the board, I felt comfortable with our recommendation. Leaned somewhat more toward the ideal, just to have less of a negative impact. But again, this is a category where a majority of the services are happening in the facility setting. And so, I think we're at 106% of the benchmark in that facility setting. So, yeah, all to say, I think I have no suggested changes to this recommendation.
Thanks, Megan. Other members?
I feel good with it as is.
As is?
Yeah, I'm okay with it.
It's fine.
Yeah,
good.
Me too.
I think that's unanimous. Thanks, everyone. And we go to digestive system. We were at 96% overall on the benchmark. Ideally, the non-colonoscopy bring codes under 80 to 80, above 100 to 100. For colonoscopy, bring codes under 130 to 130 and above 130 to 130. And then increase the rates by 3% without codes. That'd be a $41,000 savings. And then on the pragmatic side, we said non-colonoscopy the same, but colonoscopy bring codes under 130 to 130, above 130, down to 130. Oh, sorry, the non-colonoscopy is above 85, down to 85. So there's a $318,000 savings here. In either case, we'd be right about 95% or 94% of the benchmark. Here's your facility, non-facility split. Most of the dollars here are in facility, 96%. And most of the utilization. No public comments. What do you think?
Same here. Like, I feel comfortable with the recommendations. Somewhat favor the ideal recommendation.
I feel the same.
Tim too.
I'm good.
Any opposed to keeping the recommendations? Okay. Next up. Oh, we did this. Integumentary system. Here we were at 84.7. Ideally, we would go codes under 80 to 80, those over 100 to 100, and increase by 3. That'd be an $80,000 fiscal impact. But pragmatically, we could say bring codes under 80 to 80, codes above 85 down to 85, and the 3% for those without. That would yield a positive fiscal impact of $262,000. Here's your facility, non-facility. Utilization is about split here, it looks like, with 60% of the dollars going into facilities. What do we think?
Same, support the recommendation, favor to some degree the ideal.
I'm
I
comfortable.
support ideal.
Others?
Support Megan's recommendation.
I do as well.
Same.
Great. Let's keep going.
Yeah. Musculoskeletal. We're at 85.2. Similar approach of bring those under 80 to 80, those over 100 to 100, increase the rest by 3. This would have a $97,000 fiscal impact. Bring codes on the pragmatic side, similar on the under 80 over, but on the codes over 85, we would bring those down to 85 here, and then the 3%. This would actually have a net savings of 400,000. No public comments. Oh, sorry. Yeah, facility, non-facility. Looks like about 87% of the dollars are going into facilities here, but utilization is split pretty evenly.
Same all across the surgical category, so support, favor ideal to some degree.
Support
Thanks,
them too.
Megan.
Support Megan.
Support.
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 All right, unanimous. Respiratory, we were at 89.5 in the last fiscal versus our benchmarks. Again, bring those codes under 80 up to 80, over 100 down to 100, plus the 3% for the rest. That would yield a net savings of 65K. On the pragmatic side, again, same. Codes under 80 to 80. This, and again, the codes over 85 would be brought down to 85 instead of 100. That would yield a savings of 233K. Looks like most of the amounts, 74%, are facility based, and most of the utilization as well. The benchmark on the non-facility would be 67% here, though, versus 100 in facilities. No public comments.
And same as above. Support, favor ideal.
I agree.
Any objections? Hearing none. Okay. And other. Here we were 88%. Exact same recommendation, under 80s to 80, over 100s to 100. That gets you 77,000 in positive fiscal impact. Similarly, on the pragmatic side, we would go those above 85 down to 85. That would then yield 700,000 in the positive fiscal. %76 of the funding goes to facilities here. 2/3 procedures utilized in facilities. Benchmark at 100% for facilities, but the non-facility benchmark at 63%. No public comments.
And same
Same.
support and favor ideal.
There you go. Rinse and repeat.
I agree.
Any objections to keeping the recommendations? Okay, well done, folks. I want to go right into the prioritization discussion. Want to make sure you have an opportunity to frame some of the larger context here. We talked about preventative services or vulnerable populations as examples. Ling Ling.
Yeah, I searched all the slide and all 7 service subcategory has negative fiscal impact for the pragmatic recommendations.
Thanks.
All like rate reduction. And second, I checked the number. I and auditory service, that category has the highest utilization percentage for non-facility. That's true.
Oh, thanks, Ling Ling. Yep, that makes sense.
Thanks.
Okay. Yeah, let's dive into the prioritization topics that you want to emphasize. Go ahead, Megan, please.
Yeah, I mean, I think from the surgical services, while I would like favor the ideal for all of them, I think just emphasis on the eye and auditory services because the majority of those services are outpatient services. And then the other areas that came up for me were just the need to take a look at what's going on with anesthesia services and think critically about that. And then we highlighted the maternity services, so Prenatal Plus and the nurse home visitor program.
Before we have everyone else go, thank you, Megan. I think this is our first time doing this, so I just sort of want to align on a quick approach of how we do it. I sort of like, Megan, what you just did, and maybe we do a round robin across each member to basically say verbally how they would steer, meaning are there any priority areas that are very important to them that they think the department should prioritize? Or within ideal or pragmatic, are there certain service lines where you really feel like ideal is more appropriate or pragmatic is more appropriate? And so each member would have 1 to 2 minutes to basically just share their thoughts, and we do a round robin. Megan, you're welcome to do more. You kind of did your round robin, have to give you more time to do a full round robin, and we just go across all committee members, and that's meant to be qualitative input to HICPUF to help in getting to final recommendations. Does that work for both the committee and for the HICPUF team, just so that we're being helpful to you all?
Yes.
Can we advance the slide, 1 slide, please? This probably will help y'all at least a little bit. But go ahead.
Sounds like I got a yes from Anisha, and I'm seeing thumbs ups. Anyone opposed to that approach? Okay. Oh, go ahead, Michelle.
Yeah, just a quick time check. We are almost at 2 p.m. If the meeting needs to go a little bit over, can the committee stay just to kind of knock it out today? Looks like we're almost there. We might be able to
I
get through
think we
it.
can get there. I think if we're doing 1 to 2 minutes per person, we can kind of get there by 1:55 and leave 5 minutes to wrap would be my thoughts.
Okay, perfect.
Okay.
Thank you.
All right. So I think we heard from Megan. Megan, if you want more time, please let me know. I'm just going to go in the order that I can see in my Zoom. So Manisha, you are next in my Zoom, and we'll pass to you for global reflections and prioritization across the whole portfolio.
For me, the thing that stood out the most and will have me thinking for a long time would be any MT that feel that industry is at the verge of collapse, and I would really like to prioritize getting there, so just so they do not stop or forced to stop what they are doing. And among surgery, like Megan said, eye and auditory, I am also okay removing the pragmatic there, just so it emphasizes that how important is it to keep the ideal recommendation there.
Great. Thank you. Next in my Zoom is Kate.
Hi, I don't have anything else to add, except that I am going to put something in the chat. Again, it's from a behavioral economics perspective, showing how caps and copays and things like that, all they do is disincentivize behavior for utilization. They don't actually are cost saving. So I'm just going to put that in now, and that's it.
Thank you, Kate. Christopher.
I think I would push for leaning towards the ideal on 3 categories, and that's NEMT. Although I'm not sure that anything we're going to do there is going to address their current crisis situation. It's unfortunate, but it's happened. DIDD, dental, and pediatric behavioral therapies. And then I don't know, I 100% understand the reappropriated funds from the tobacco master settlement. How does that money work?
I
On
can
that
speak
one,
that
it's the home visitor program, it's the only one.
it's just that it came from the tobacco settlement, however
Okay.
many years that was. It was a very lump sum. It went to all the states. It was distributed to the states to use as they see fit, and it will eventually run out.
Okay. That's
Yes.
how I understood it. I wanted to make sure
Yeah.
that there wasn't some more money somewhere.
Not unless you want to sue Philip Morris again.
No, that's okay.
Okay, great. Nicole.
Yeah, I would just echo exactly what was said about the services that are on the verge of collapse. I think we're probably not the most effective mechanism for immediate change, but I think that those are ones that we really need to kind of think about the methodology and have a better understanding of how we're getting to those spaces where we're seeing that the changes that are being made are causing disproportionate impact. So I have concerns on that. And the caps, I agree.
Great. I think I cut everyone except myself. Is that right? Did I miss anyone? I don't think I did.
What about
You got
Tim?
Tim.
Oh, sorry, Tim. Sorry.
That's all right.
Sorry, so sorry. Go ahead.
So I obviously am very concerned about the NEMT. So I'd like to see that as a top priority that we address, because I think it's also going to involve a fiscal note that we're going to have to get through the JBC as well. And I would also like to prioritize those other services that we're requesting additional work from HICPUF on, because that will have a fiscal note as well. That will need to be addressed by the JBC.
Okay, I think now that's everyone, right? I haven't forgotten anyone. Okay, I will wrap with my thoughts. I agree on NDMT. I'm not sure if ideal is right by looking at the data, but the level of urgency from the community feels real. And so doing something there, even if it's just additional analytics to ensure that we feel good around access to care for this service, I think is very important. I think the 2 maternity services are also important, given the just force multiplier effects of early intervention, prenatal intervention, so prenatal plus and nurse home visitor program. I think in PBT, the family treatment guidance and exploring that further is really important. I think that can be a force multiplier in Medicaid. And then I agree with the comments on the surgical systems and leading more towards the ideal side of the spectrum rather than the pragmatic, given the rate impacts there. So I think that is everyone. Is there anything else, HICPUF team, from a committee perspective that we can be helpful with before the report is written?
We will, for example, like you agreeing to lean on the ideal recommendation for surgery. We can put that note in the report. But for those detailed global reflection or though thinking, I think for Ian as the chair, maybe it's better to talk to the JPC directly during your meeting time with them. Because now our leadership expect us to make our report short.
I'm fine with that. I think our job is to speak our voice. So I think hopefully the voice that we're speaking here can be influential, as you all write the report, and then I will try and speak that voice of the committee when we present in November or whenever the presentation is. And yeah, so that sounds good to me.
Thank you.
Okay, I think we are good and we can keep going.
Tim?
Sorry, couldn't find my mute button there. And this is just a question, Brian. We know this is an election year. We know Ian is going to be presenting the JVC in November. We know that there's going to be new members of the JVC come January. Is there a possibility that there may have to be a second presentation to the JVC regarding the Mprrac recommendations? Because the new committee is going to have to understand what these recommendations are, what they mean in our perspective.
That's a good point, Tim. I'm not sure we have a plan for an earlier, excuse me, another JBC meeting. But we
It
may.
is always possible. There is only a requirement for one. They can always ask for it, and then we'll pass that request along to you guys if they are asking for new or another presentation from the committee. I would say most likely they're going to want just a recap of what had already happened from their staff or something like that.
Okay, I should have brought that up earlier in the meeting, but I was thinking for poor Ian's sake that he may have two presentations to do.
Yeah, appreciate the question. Other questions or topics here as we start to wrap up today?
I had a question about the November meeting, and being my first year, from what I was getting, everybody's comments today, do we reach out to Michelle or the MRAC committee to just put in some titles, line items that we can speak more about during the November meeting, or do we not bring it up until November at all?
We definitely want you to think about, ideas to improve our process, right? Areas that are the most, for example, areas that of the data analysis and so on that are the most valuable, or areas that you think we may be able to cut back a little bit on because they don't provide you with, material information to make a decision. And then certainly we want to talk about, we'll do some training for those and make sure people are comfortable with what's coming next year, that kind of thing. So if there are, we definitely will be asking what suggestions you have to bring to the table, and feel free to share those ahead of time if you like with Michelle. If there's things that we can look into as a team ahead of time, I'm sure we would. So
thank you.
Yeah, and just as a reminder, just send them directly to me, not as to the committee as a whole, just so we don't violate any regulations or anything like that, since everything needs to be discussed publicly. So if you have ideas ahead of time, send them directly to me. I can make a note of it and we can work it into our presentation.
And Michelle, would this include the joint, I'm thinking, I'm wanting to get a historic context on how much we recommend is kind of adopted by the JBC. Their information is publicly available too, I'm sure.
What information?
The JBCs, all of their notes, their minutes, what they adopt, what they don't adopt.
Yeah, and there's I think at the beginning of the presentation there's links to like their website and everything that will house all of that. Yeah.
Yeah, you can go and watch Ian's presentation.
Yeah.
It's live streamed, so if you want to,
I will be. It must be.
Yeah, you can be there.
It's public. Yeah.
Yeah, and I'll also send that link out to the committee as well once we have it and everything, so that way you don't have to go searching for it. It'll just be on your calendars already.
Thank you.
Anything else? That
Bria,
may wrap
can
up
you
my
skip
part.
forward to the next few slides. Yeah.
One more. There it is. Michelle, I'll turn it over to you.
Okay, thank you so much, Brian. Okay, so as we just discussed, next meeting will be November 6th. We originally had that backup meeting planned for next Friday in case we went over today. We're not going to go over by 3 minutes. We made it. So I'm going to delete that off of your guys' calendar. So no meeting next week. Next meeting will be November 6th, our usual time, 9 a.m. to 2 p.m. Next slide. And again, like we just mentioned, start brainstorming now for any areas of improvement that you can think of. Send them directly to me. You can also, you don't have to share them with me ahead of time. We can also just discuss them live in the meetings. So either way, but next meeting is for planning for the future. So come prepared for that. As always, we'll get the meeting minutes to the chair and vice chair and then to the rest of the committee. Our goal is to always post everything a week after the meeting. So be on the lookout on our website for the updated materials and the meeting summary and the meeting recording. If you have any further feedback that you want to send to our team, you can feel free to use those email addresses there. We always encourage stakeholder feedback to be sent to that first email address, which is our whole team's address. That goes to everybody on our team. So please make sure you're using that email address if you're going to share stakeholder feedback. It will be shared with the committee, but you can feel free to reach out to Ling Ling or myself as well. Okay, Ian, I'll hand it back to you.
Thanks, everyone. Thank you for an engaging and productive discussion today. With that, we will adjourn. We will see you all at the next meeting and at the JBC presentation. Hope you have a great day.
Thank you.
Thank you all so much. See you in November.
Bye.
Thank you all. Take care. Good luck.